Good morning, everybody. It's Sophie Scott here. I'm going to be your host for this important symposium today. We're about to get underway just while everyone joins. So thank you very much for your time here today. As I said, my name's Sophie Scott. I'm the medical reporter for ABC, and I'm going to be your host. And it's been an important time for mental health in Australia with the report of the Royal Commission coming out and a whole lot of other reports. And today is all about putting it all together, and that's what we're going to be discussing. So we really appreciate your time being with us today. And as I said, it's going to be your conference, so we really want you to get involved. But I'm going to hand over to the CEO of Mental Health Victoria, Angus Cleland, to kick off our event. Please welcome Angus.
Thanks, Sophie. It's terrific to be here once again for day 2 of our symposium. On a particularly fine and sunny morning here in Melbourne. I'd like to start by acknowledging the traditional owners of the lands on which we're meeting today and pay respects to elders past, present and emerging, and also to acknowledge the traditional owners who are participants or presenters here today. I'd also like to acknowledge the incredible depth of lived experience as well within the virtual room, and to acknowledge the individuals, the mental health professionals, the academics, the community members and others who are up here with us today. I should note, and I'd like to advise people again that some of the discussion today may be triggering and difficult, and there are a number of support options up on the screen there for you. Of course, as a virtual event, we have the benefit of the session being recorded and being available via YouTube, and hopefully everyone will receive the link to day 1 recording, which went up on YouTube last week. And certainly within a few days, this one will be available there for you. But please make use of those services if you feel you need to. And I'll hand that now back to Sophie.
Thank you very much. Thanks, Angus. And as I said, this is going to be your conference today. So it's really important that we want you to get involved. So the theme for today is putting it all together, and there's been a number of reports, and today we're going to pull everything together with a whole lot of amazing experts that we've lined up for you. If you're on Twitter or social media, we would love you to get the message out. So the hashtag is putting it all together, and if you can include @MentalHealthVictoria, and my handle for Twitter is @SophieScott2. So if you're on Twitter or Instagram, it's @MentalHealthVic and @SophieScott2. And we really appreciate everyone who's taking part today, particularly those with lived experience or carers or people working in the sector. And as I mentioned, this is your event, so we want you to be as involved as possible. And that means you have the opportunity to ask questions to pretty much all of our speakers today, which is a fantastic opportunity. So you'll see, just like any other Zoom meeting, there's a Q&A box at the bottom. And if you want to ask questions, please pop your questions in that box, and we'll try to get to as many of them as we can throughout the day. We will be having breaks, and during the breaks, it's a great time to visit the exhibitors hall. So you would have received a link for the exhibition hall with your pack today. So we really encourage you to go and pop over there and have a look at all the sponsors who've helped make today a possibility. As I said, we really want you to get involved. This is your opportunity to discuss these really important reports: the Productivity Commission, the Vision 2030 and the Suicide Prevention Report, and the National Child Health and Wellbeing Strategy, and how we put it all together with the Victorian Royal Commission as well. So it's now my great pleasure to introduce our first keynote speaker. Damian Ferrie is the Chair of Mental Health Victoria. He's had leadership roles in health, housing, community development and transport sectors in New South Wales and Victoria. And his work has focused on the important issue of tackling social, economic and health inequity. So please welcome Damian.
Good morning, everyone. And can I begin by acknowledging the traditional owners of the land on which we are speaking from? I pay my respects to elders past, present and emerging, and also acknowledge the members of the Indigenous community who are speaking and participating in today's event. It's amazing to think how far we have come in just a few short years. In April 2018, the newly established Mental Health Victoria brought together a diverse group of stakeholders from across the mental health sector. Peak bodies, community organisations, public hospitals, unions, police, professional associations and medical colleges to collaborate and coordinate their advocacy efforts. The result was saving lives, saving money. The case for investment in Victoria's mental health. This document, which was made the very public case for reform and investment in Victoria's mental health system, sent a sign that the mental health system's often competing stakeholders were prepared to advocate and campaign together in the interests of a better outcome for Victorians living with mental illness. There is little doubt that this demonstration of unity was decisive in what was to follow, a commitment to hold a Royal Commission into Victoria's mental health system. Since that pledge was made on a very cold and windy day at Kyneton's Men's Shed in October 2018, through to the release of the Royal Commission earlier this month, we have witnessed extraordinary commitment to the reform process, despite incredible hardships and pressures created by the pandemic. As we move into the implementation phase, we need to redouble our efforts. To get it right, we need to commit to even greater collaboration and to draw on the collective knowledge and leadership of the sector. As the Deputy Premier stated on day one of the Symposium, this important series, all of us need to ensure that individuals living with mental illness are at the very centre of all that we do. And on behalf of Mental Health Victoria, I'd like to acknowledge the ongoing support of Ingrid Olsis AM and her fellow members of the Mental Health Victoria Lived Experience Advisory Group. Can I also encourage anyone or organisation who'd like to become actively involved in the work of Mental Health Victoria, especially as a member, to contact our office. While much of our focus has been on the Victorian mental health system recently, we need to remember that the mental health is a responsibility of both the federal and state governments. For the Victorian Mental Health Royal Commission reforms to be truly effective, we need the federal government to commit to its own reform agenda, which is why it's so pleasing that today in our series, we'll hear from Professor Stephen King about the Productivity Commission inquiry into mental health. We'll hear from Christine Morgan from the National Mental Health Commission about Vision 2030 and the National Suicide Prevention Plan. And Professor Christine Middeldorp and Professor Frank Oberklaid about the National Children's Mental Health and Wellbeing Strategy. The convergence of all these proposed federal reforms with confirmed and funded reforms from the Victorian Royal Commission make 2021 an incredibly important year for all of us. We hope and anticipate that the federal government will make its own historic commitment to mental health this year. The signs are looking very positive, but we need to continue our collective advocacy to make sure that it happens. To all the participants today, I hope that today's program will inform, encourage, and inspire you. To all the speakers and the panelists, I wish to express our collective gratitude for your generosity in giving us your time today. Thank you and happy St. Patrick's Day. we believe that some very important pieces of work have been done from a state and federal level over the last 12 months. And we acknowledge that many other states are looking at the relationship that is developing between Victoria and the Commonwealth in this important work. And I think we'll hear from speakers today that, in fact, dovetailing primary, secondary and acute sort of services are really an important part of the whole picture. And I guess what we've learned in our reform process in the last few years is that we need to approach these common issues of encouraging healthy and productive relationships between the sectors, as also we can't start competing for funding in a way that destroys both collaboration and leads to that sort of siloed approach to dealing with both treatment that excludes and isn't actually modelled around the individuals and their needs.
And that's certainly what we heard in our previous symposium about everyone working together and collaboration. And I'm sure that's going to be a theme of today's event as well. So look, Damian, thank you so much for being part of this event and your warm welcome and setting the day out, the wonderful agenda. And we do encourage all the audience to get involved, and we really appreciate you being here to set the day and set the tone for what's going to be a wonderful symposium. So thank you very much.
Absolute pleasure, Sophie. Thank you.
And we're a little bit early, but we might just take a short break just to fix up this little audio issue. But we'll be back here at 9:30, and now is an amazing time if you would like to jump over to the exhibition hall, have a look at our sponsors, grab a quick cup of tea, and we'll be back at 9:30 for our first keynote speaker, the Productivity Commissioner, Professor Stephen King. He'll be back with us at 9:30, so we'll see you then. Welcome back, everybody. I hope you had enjoyed that little short break. We're going to get stuck into today's events. We've got lots of amazing speakers for you. So we're delighted to have the speaker to talk about the Productivity Commission report. The recent Productivity Commission report into mental health is one of the most wide-ranging inquiries ever held into mental health in Australia. It's broad in its scope and also recommendations, and we're delighted to have the presiding commissioner of the inquiry, Professor Stephen King, with us. And before joining the Productivity Commission, he was a member of the West Australian Economic Regulatory Authority, the National Competition Council, and Professor of Economics at Monash Uni. He has a Master in Economics from Monash and a PhD from Harvard. And we're delighted that he's made time for us to be at this important symposium today. So please welcome Professor Stephen King. And don't forget, there's going to be time for questions at the end. So think about the questions.
Thanks for that, Sophie. Hopefully you can hear me because something just suddenly went funny with the sound. Let me know if you can't. And let me just start by sharing my screen. And popping it up on full screen. Okay, so let me start off by acknowledging the traditional owners of the various lands on which we are meeting today. In my case, it is the people of the Kulin Nation, and I'd like to pay my respects to their elders past, present and emerging. I'd also like to thank the many consumers and carers who shared their stories, their experience, their knowledge with the Productivity Commission when we were developing our inquiry report. Without the help of those consumers and carers and their courage to come forward and tell their stories, often in a public forum, we could not have written our report. So over the next 25 minutes or so, what I'd like to do is give a helicopter view of the report. I'll do a deep dive into a couple of recommendations, but I certainly won't go through them all. So let's get started. Oops. There we go. Let's just start off with some background material. First off, many of you will know these details, and you will have seen this sort of diagram before. Around 1/2 of Australian adults at some time in their life will meet the clinical criteria, the diagnostic criteria for mental illness. That's around 1 in 5 Australians each year. There is obviously a spectrum of mental ill health from mild which is around 2.3 million a year, through to a group of people who have severe mental ill health in any year. It's important to recognise that people move between categories. So your mental health can deteriorate, you can be living in community, maintaining employment, maintaining a full productive life, but your mental health can deteriorate, and you need to make sure that the supports are there as your mental health deteriorates. So the sorts of services that we need in mental health are going to need to cover all of these population groups. They're also going to need to be dynamic enough so that they can deal with people's changing mental health requirements. Another factor that many of you will know is that unlike physical chronic ill health, mental illness strikes early in life. So young people aged 16 to 25 years actually have the highest prevalence rate for mental illness. And most people who develop mental ill health as an adult will have first symptoms before their mid-20s, and many will have their first symptoms in their teenage years. That means it's a health challenge. Mental illness is very different from other chronic ill health that tends to affect people later in life. It means that mental illness is most prevalent when people are involved in their education years, when they're moving into the workforce, critical years for their ability to be able to participate broadly in the community throughout the rest of their life. The final background information, which comes from our report, is that mental ill health and suicide is very, very costly to Australia. These are the Productivity Commission estimates from our report. We estimate that in a pure economic cost, simply dollars and cents, then the cost of mental illness is around 43 to 70 billion a year, made up of healthcare services, lost productivity, including inability to attend employment, inability to function fully in your job, and inability in some situations to be able to hold down a job. And 15 billion in informal care, those most important but unpriced services provided often by family and friends. We also estimate around another 150 billion, so twice the highest bound on that economic cost, as being the cost of diminished health and reduced life expectancy. That life expectancy gap of around 15 to 20 years for people who have severe mental ill health. The loss of ability to participate, the pain associated with mental ill health. Our estimate of that is about 150 billion, just using standard quality of life measures. In total, these come to around $220 billion per year in Australia. And to put that in perspective, in 2019, so pre-COVID terms, that represents about 10% of everything Australia produced. So these are very, very big numbers. Now, there's been numerous mental health inquiries before. Why is the Productivity Commission one different? Why, hopefully, will our inquiry provide one of the platforms to move forward in reforming the mental health system? Well, let me put up these 4 criteria for why I think we're different. The first is that it wasn't an inquiry undertaken by mental health experts. Broadly speaking, the team were economists. We had significant assistance from Professor Harvey Whiteford, who is a psychiatrist, but the team generally were economists. And economists, as some of you will have heard me say before, economists come at an issue with a particular perspective, as do any professionally trained individuals. But the perspective of economists is a consumer-centred or a person-centred perspective. So from an economist's perspective, when looking at something like the mental health system, the starting point must be that the value of any service must reflect the value to consumers. Or in other words, the mental health system isn't designed for the benefit of service providers or medical practitioners or politicians. It's designed for consumers and carers. And the only way we can tell if the system is being successful is to ask, are the right services, the services valued by consumers and carers, are they reaching consumers and carers? So you'll notice a fair bit of our report looks at various stages, input from consumers and carers into the mental health design process, going from the very highest level of system design right down to service level in a local region. And maybe that's an economist's bias, but it does reflect the economist's way of thinking. You wouldn't go out and design a car without asking consumers what sort of car they want. Occasionally, car companies have done that, and they've been pretty disastrous. Similarly, you cannot design a mental health system. You cannot design a mental health service without asking the consumers what they want, what they need, and is this service meeting their needs? So that's the first part. You'll see in a number of our recommendations that we say we need consumer and carer input into the process right through the system. And it's not tokenistic input. It's got to be real input into service design. Second reason why this is different is it, again, is not a health inquiry. As I've already mentioned, the services that you need to help deal with mental ill health will differ over your life. They will also not just be health services. They include services in workplaces, in education systems, in the justice system. They include community supports to enable someone with mental ill health to recover in community. This means that you have to take a cross-portfolio and a cross-life perspective. And that's what we've tried to do in our report. That means that our framework is really thinking about getting the right mix of clinical and non-clinical supports over that spectrum of mental health needs. And there will be some people who will need very highly intensive clinical supports, but that same individual at another stage of life may need very little clinical support, but they may need a lot of non-clinical support, a lot of psychosocial supports, for example. And finally, we've tried to create a roadmap for reform. We've been realistic, we hope. We recognise there's no blank checkbook for politicians here. We've got 21 recommendations. We've got 103 action items in those 21 recommendations. But there is no point giving government just a dump of 103 action items without providing them with some guidance as to where we think the priorities are, what should go first, and what delivers, in simple economic terms, the biggest bang for the buck. On the basis of costs and benefits, where should the government be starting? And hopefully that we've done that in our approach to our recommendations. So how have we prioritised reforms? Basically on these 4 criteria. We've looked at those reforms that have the biggest potential to improve lives. That may be at an individual level, but it also may be at a broader community level. So I'll come to our education reforms in a second, and you'll see that they provide very large potential gains for Australia, but they're not individually focused. They're focused on young Australians in an education setting. We also then looked at the benefits to the economy and the expenditure required to achieve these. Yes, we're economists, so we look at cost-benefit analysis. The third step is ease of implementation. Being realistic, things that are easier to implement are more likely to be implemented. And finally, we look at sequencing. There are some things that need to be done before you can move on to the next steps. So you have to make sure the foundations are built before you try and build the new system on top of those foundations. To give you a bit of a feel for how these fit together, this is, it's my favourite diagram in the entire report, but I suspect that says more about me than anything else. This is, we call the bubble diagram. And what it does, just an easy way to think about this, on that vertical axis, you've got benefits and costs. You have that simple economic question. is the dollar saving bigger than the dollar cost. And anything above that horizontal line, the dollar saving is bigger than the dollar cost. Then on the horizontal axis, we've got the additional quality of life here. It's the improvement to individuals and to the community in terms of an improvement in quality of life. This diagram, from an economist's perspective, is sort of shocking, because there are a lot of things here that are above the line. And we couldn't measure everything, but what we could measure, and obviously often we had to accumulate things together, and we were pretty conservative. But anything above the line there represents a policy or a group of policies where the dollar benefits outweigh the dollar costs. So for example, individual placement and support has a dollar benefit outweighing the dollar cost. The black dots are blown up on the lower right-hand side. So suicide prevention, for example. Suicide prevention programs have a dollar benefit that outweigh the dollar cost. And I'll come back to talking about a particular example of that in a few minutes. These are free lunches from an economics perspective. And one of the jargon lines in economics is there's no such thing as a free lunch. So we have to start asking why, if these policies actually create dollar benefits greater than the dollar costs, haven't these policies been done in the past? And so we identify barriers to those reforms. And the barriers fall into three broad categories. Firstly, many of these reforms involve an investment today for a long-term payoff. So you're spending today and investing in the community to get better mental health payoffs in the future. And that can be hard. That can be hard for governments to do. Secondly, many of these reforms involve cross-jurisdiction activities, where, for example, the federal government may need to spend more in primary care, and that will lead to a saving in hospital costs. But hospital costs, of course, are a state and territory responsibility. And it can be hard to get that coordination between state and federal governments. Unsurprisingly, one of our core recommendations is that those governments need to sit down and create a new agreement, a new strategy, make sure they work out who's responsible for what and also who pays for what, so that we can move forward, because that's going to be a foundation to getting these reforms in place. And the third is cross-jurisdictional. Sometimes, such as individual placement and support, you're spending in one portfolio, employment, but the benefits flow through to another portfolio, such as health. Or you're spending in housing to get benefits in health. Or I mentioned I was going to talk about school aid support. You can see that there on the green line. It's on the green dot on the right-hand side there. It actually has a cost that's bigger than the benefit, but a huge potential gain in terms of early intervention in the progress of mental ill health for young Australians. That again, though, is cross-portfolio, spending in education, a state level, to get the benefits in health, both at a state and federal level. So those barriers need to be overcome in order to move forward. We've got 5 broad areas of reform: prevention and early help for people, prevention and early intervention, early in life and early in disease. Improve people's experience with mental health care. While we're not doctors, we're not medical doctors, a large part of the mental health system is mental health care, and we've got a large number of recommendations relating to that. Improve people's experience with services beyond the health system, as I've already said. So community services, justice services, services in schools, services relating to housing, services relating to employment. All of those are critical. They're critical parts of the mental health system, and we need to make sure that those services are there. We need to equip workplaces to be mentally healthy, and we need to make sure that governments, local authorities, local health authorities, people right through the system, face the incentives and are accountable for improved outcomes in mental health. So, about 12 minutes, I'm going to duck into a few of the reforms in detail. I'm definitely not going to do all the reforms. But priority areas under prevention and early help for people, mental health for new parents, you will have seen some activity in that area in the last federal budget. I've already mentioned social and emotional development for school children. That needs to be a national priority. National stigma reduction strategy. Stigma is a significant problem in the mental health system. It is a barrier in the mental health system. What stigma does is it disempowers consumers and carers and undermines the services and care for consumers. And unless stigma is dealt with, we can have great sounding reforms, but the implementation will be undermined by stigma. What do I mean by that? Well, stigma arises in many ways. Community level stigma is an obvious area of concern. But stigma also exists at a professional level. And the evidence is quite clear that if someone with a history of mental ill health, with a physical ailment, sees a medical professional, then they will systematically be treated differently to that same person with the same physical ailment without the history of mental ill health. That prejudice, that discrimination, that stigma will mean that the person with a history of mental ill health does not necessarily receive the treatment that they require from those medical professionals and from other professionals. So professional stigma is an issue. And self-stigma, which I found really distressing, hearing the stories of self-stigma. For example, individuals who were trying to deal with their own mental health were not receiving the support that they needed. And for example, in the workplace, their response was to then say, oh, I'm letting my team down, I need to work harder. And so, and I'm thinking of a particular individual, some of you may have read this individual's submission, it is on the PC website. This individual made themselves a model worker. They were in before everyone else, they were out after everyone else, because they felt they had to do that because they felt that they needed to make up in some sense for the fact that they weren't feeling mentally well, but they felt they were letting their team down. And interestingly, when in that situation, we and other situations, we've asked other people, and other people have also done these same sort of surveys, was this colleague letting you down? The answer is almost always no. So we need to deal with that self-stigma, the fact that individuals who have mental ill health need to make sure that they can access the supports that they need, rather than in some sense blaming it on themselves. Now, there's no simple answer to the deep-seated stigma that exists in Australian society surrounding people with mental ill health. But we do need to start on a solution now. We know that we can change community attitudes. We've seen community attitudes change in other areas of stigma and discrimination. It includes, and our recommendations include, things such as improved education for medical professionals, but it needs to be broader as well. It needs to be community driven. And we recommend that the National Mental Health Commission be tasked with driving that ongoing stigma reduction strategy. And it will not be a short-term win. This is one where we will need to spend over time to get the gains, but the gains will be a necessary platform to build a mental health system, a functioning mental health system. Follow up after suicide care. That's the next one I want to briefly touch on. We highlighted this actually in the draft report, and the evidence simply confirmed from the draft report. That was one of those that was above the line, if you remember. This is one of those where the benefits outweigh the costs, just in a purely economic sense. The numbers are down there on the slide. So if you see the first line of the blue part, follow-up care, that is the payoff per dollar invested in simple follow-up care for somebody who has come into a hospital or medical clinic following an attempted suicide. We know that that is a significant indicator of a future suicide attempt. In simple follow-up care, simply after the individual is discharged, contacting them, ringing them up in the following days, in the following months, can significantly reduce future suicide attempts and the cost of those attempts. And for every $1 invested, the payoff appears to be 2 to 7 times that dollar in terms of the dollars that you get back, not even considering the benefits to the individuals, to their families, to their friends. So again, this is one of those free lunches where we think there needs to be action. Improve people's experience with the mental health system. I'm not going to run through these. There, as I said, mental health care is a significant part of our report, as you would expect. And there's gaps right across that spectrum of individual healthcare needs. And I want to stress that there really is sort of no area where you can say, yes, well, there's too many services there. We think services can be improved. We think they can be levelled out. We think that new services can be introduced. Let me show you what I mean. Oops. Key element here is getting people the right services at the right time. So here's our little graph, our little diagram, which summarises the existing system. So the orange line refers to, or you can think of those as population shares. So remember back to that earlier graph, quite a few people with mild, smaller amount with moderate, and smaller amount with severe. Think of that as that orange line in terms of service intensity. And the number of people is simply measured by the height of that orange line. The blue line represents current services. So it bulges up in the middle. It bulges up in the middle because of better access. Better access, so psychological therapy delivered in general face-to-face. Certainly when we started, it was delivered face-to-face pre-COVID-19. About 1.3 million Australians each year access those services. But despite the fact that that is an area where there's lots of service, many people who access those services access fewer than 4 services, fewer than 4 sessions under better access. And we know that that's in general too few to make a clinical difference. But we also know that many people reach their 10-session limit under better access. So we think with better access, there needs to be some changes. The first thing that needs to be done is an evaluation to make sure that those face-to-face therapies that are clinically proven, to make sure they're actually working well in the field. How do we do that? Well, we have to start by getting outcome measurement. What is that? PREMs and PROMs, patient-reported outcome measurement. In other words, the face-to-face therapists actually have to start asking and recording and reporting what the consumer thinks of their service. Because surprisingly, that is not systematically done at the moment. And we recommended, and we saw this being implemented in the federal budget, last federal budget, trials of more sessions for those who need more sessions under better access. What about the other 2 areas? They're the areas where the services are too little. Let me start off on the right-hand side. The missing middle. Many of you know about the gap in services. It's called the missing middle gap. The fact that we need more non-acute beds, we also need more acute beds. We need, as I said, more therapy sessions, face-to-face therapy sessions. We need more community ambulatory services. We need more care coordination. There's a whole range of services that are missing, so that individuals who start deteriorating in community have nowhere to turn to until they end up at an emergency department. And we need to make sure that that isn't the path that many Australians with mental ill health take. We need to make sure the services are there so they don't need to go to emergency. And we need to make sure that when they do need hospitalisation, that there's appropriate pathways in. And when they leave hospitals, there's appropriate pathways to step down out of hospital, to be supported in moving back into community. So you'll find lots of recommendations there. We've also highlighted what I'll call the low intensity gap. Many people with mild anxiety and depression in particular, they either deal with it themselves, sometimes with the dubious assistance of Dr. Google, or they'll go and see a GP, and GPs can refer them to face-to-face therapy, but the most common service that a GP will provide or will recommend is actually a prescription, often for an antidepressant, and our antidepressant numbers, medicine numbers, are clearly out of line with other developed countries. But there's a gap there. Many of these individuals, if they can receive information, if they can have access to supported online treatment such as MindSpot, they will be able to get better. And so we need to fill that gap at low intensity through online services, supported online services, group therapy, and other therapies. That, by the way, has a benefit in that you don't need an 8-year clinical psychology degree to help somebody with mild anxiety and depression. Many other people are able to provide those similar services. So hopefully these reforms will help free up that highly trained clinical workforce to move down to the missing middle and start providing more of those missing middle services. Improve people's experience beyond the health system. As I've already mentioned, we need to think about services in communities, and we've got a range there. Helping our first responders, making sure there's no discharge from an institution into homelessness, for example. Very briefly, because I want to turn to question and answers, legal representation for people facing mental health tribunals. It matters, the data's clear. We've got a nice experiment because legal representation differs between states, and you see different outcomes for people between states when they're before mental health tribunals. Worse outcomes if they don't have legal representation. It's not an economic argument, but it's a straight do the right thing argument. But these individuals should get appropriate legal representation when they appear before a mental health tribunal. Mentally healthy workplaces, I'll skip over that. But unfortunately, our workers' compensation system has been designed for physical health. It hasn't actually been designed for mental ill health. So it's all about responsibility and liability. That's easy if there's an oil spill on the factory floor and you slip on the oil and you break a leg or you break a hip. That's not how mental health works. So trying to say, did the workplace cause the mental illness? You can't tie it down like that. And often workplaces, mentally unhealthy workplaces, will be a factor. They will trigger mental ill health. Trying to say, trying to thread some sort of legal needle is pointless. So we recommend no liability clinical treatment for mental health related workers' compensation claims. It's actually very cheap and will help get more services to those who need them quicker. Finally, instill incentives and accountability for improved outcomes. This is where the government comes in. We need 3 levels. We need a national strategy. We need state and territory governments and the federal government to sit down and work out who pays for what, who does what. I've already mentioned that. We need to make sure we have regional planning. At different regions of Australia, there are going to be different requirements, there are going to be different services on the ground. We need to work out what are the needs, what's being provided, what's the gap, and then we need to fund that gap and get the services out there, including those psychosocial services and community supports. And finally, we need that the overarching, the body that can oversee the system, make sure that reporting is occurring, make sure that the programs that are being rolled out at a regional level are evidence-based. And we see that as being a role, for example, for the National Mental Health Commission, an expanded independent National Mental Health Commission that is able to oversee the system. Again, consumer and carer participation and advocacy is important right through the system. And we need to make sure that we focus on the outcomes of that system. And by outcomes, we mean the outcomes to the consumers. So, how much will this cost? What are the benefits likely to be? And you can say these numbers are either big or they're small. All reforms on the left-hand side, priority reforms only on the right-hand side. So even just doing our priority reforms, they'll cost up to about 2.4 billion, but they'll increase economic participation by about 1.1 billion, savings of up to 1.2 billion, and a significant improvement in quality of life, as measured by those 77,000 QALYs. But it will come at a net cost to government. There isn't overall a free lunch in the reform. But these are big numbers. 16 billion in improvement in quality of life. But they're also small numbers. And because of that, they represent really a first step. Because remember, the costs were more than 10 times this. So hopefully the Productivity Commission report has laid down a roadmap of reform. I think it will be, possibly up to 10 years to put in place that roadmap, along with the other reforms coming out of the Victorian Royal Commission, coming out of Christine Morgan's report. It's going to take time, but they should be viewed as the first step on a longer road of reform, because there are many, many further gains that we can make. So I've gone over my time that I wanted. I'll escape from there. Hopefully you are now no longer seeing my slides. We can open up for questions.
Thank you very much, Professor King. That was absolutely fascinating and a great summary of your report. We really appreciate it. We do have lots of questions, so I've got a couple and then I'm going to go to the questions from the audience. I guess the first question would be, what's been the response so far since you put the report out? What's been the reaction?
I think overall the reaction has been fantastic. Obviously, you don't please everybody all the time, and so there's some parties who have come back and said, "Oh, you didn't push forward on our favoured service," or "Oh, we think the balance could be a different way." There's one group of service providers who currently perhaps don't have to justify their services as much as we recommend they do have to justify their services. In our report. Interestingly, I had feedback, as many of you know, my wife's a clinical psychologist, and she gave me feedback from one of her friends who said, "Oh, when I heard Stephen and a bunch of economists were going to report into mental health, I just thought they'd cut back on better access and that'd be the end of everything." And so, maybe the bar was so low when they heard economists were doing it, they were happy with what we did. One of the things I think that's really very pleasing, though, about the response to our report is that it is apolitical, in the sense that nobody's come out and sort of said, "Oh, this is a left-right issue or a Liberal or a Green or a Labor Party issue." Everybody seems to be behind this. And not just, and again, I want to say it's not just our report, it's our report, the Victorian Royal Commission, Christine Morgan's report. There is a group of reports all pushing in the same direction. And that becomes very hard to ignore, and they're not political. And I think the momentum is there to get real change.
Yeah, look, that's exactly right. And that's why we're sort of doing these symposiums, to sort of look at all these reports and see how they all work together. You mentioned you come out from outside the mental health sector, being an economist. What's your key observation or takeaway from what the mental health sector could be doing better or should be doing better as an outsider sort of looking in?
asking for consumers. As an outsider coming in, and particularly as an economist coming in, the level of stigma, and hopefully I tried to communicate that during my talk, the level of stigma is horrifying, but also the fact that you have a system that is meant to be providing services to a group of Australians and almost never asks them whether they're getting what they need. And for an economist, you wouldn't run a childcare centre that way. You'd ask the parents on feedback. You wouldn't run a university that way. You would, well, although some of them tend to, you would ask the students, what do they need? You'd be thinking about how do we better serve the needs of the consumer, and that's missing in our, missing in broadly in some parts of our health system more broadly, but it's so stark in the mental health area.
One of the questions we've had from the audience, which I think is important, is they've asked what's needed to ensure, because you talked about accountability, what's needed to ensure that the National Mental Health Commission has sufficient oversight and powers to ensure that accountability and to ensure that the reforms and the outcomes that you talk about in this report are achieved and sustained.
Yeah, so we recommend a number of reforms around the National Mental Health Commission. We consider that it needs to be an independent statutory authority. Now, what that means is not that it can go away and do anything that it wants. It's still answerable to government, but it's a bit like the Australian Competition and Consumer Commission, a bit like the Productivity Commission. It doesn't. Government can't tell it. No level of government can tell it what to say. It gives it a level of independence so that it can stand as that independent umpire, that independent referee. And that's important because you're going to have state, territory and federal governments all coordinating here. You're going to have services being provided across the country, and you need that independence of the umpire to be able to say, right, well, this is working in the Northern Territory, this is working in part of the Northern Territory, but it's not working in another part of the Northern Territory, or this is doing really well in northwest of Melbourne, but we've looked in the Logan area of Queensland and those same services are missing.
So someone that can keep a view of the bigger picture and keep that, sort of have that accountability across the different jurisdictions.
Oh, yeah. And that's, again, going to need consumers and carers as part of the National Mental Health Commission team.
So when the report was released, the federal government's response was that that they would be working towards their response in the federal budget. What should the sector be looking for in the budget to acknowledge that the government's looked at your report and taken it on board? What are the key things that you would be hoping to see in the federal budget to show that they've acknowledged these suggestions and that they're going to put them into practice?
Yeah, so I know everyone focuses on the budget. I actually think it's more important not to focus on the budget. So I'm sure the budget, they'll pick bits and pieces of our recommendations and some recommendations from other reports. There'll be particular services that will get more money and so on. What's really important is those underlying foundations. And I know it's up the back of the report in chapters 22 and 23, but unless we have that agreement across all Australian governments, unless we have that national strategy, that agreement on who's responsible for what and who pays for what, we actually won't move forward because there'll be missing services and finger pointing. It'll be, oh, you're responsible. No, you're responsible, and so on. So I actually think the more important thing here is the movement towards, I think they've agreed on November, as being getting that strategy in place. And I think that's what we really need to keep our eye on, because we need to have that strategy, that national agreement, and then we have the base to move forward.
And we've seen through COVID and the pandemic that the states and the federal government can work together well, which is so there is a good example there when it happens. Another question from the audience, which I think is important, is what can you advise people who might be concerned that the reforms may not be implemented soon enough and quickly enough, and there's action needed now to save lives given the stress in the system at the moment?
Yeah, unfortunately, there will be disappointment, but people will lose lives whilst we wait for reforms to come in. I'm sorry, but given where we're starting, given where we've got to get to, it's going to take time, it's going to take new resources, it's going to take guts by a lot of our political leaders. You know, and it would be great if we were able to say, right, everything's in place now. But even with the Victorian Royal Commission, where the government had committed to accepting all of the recommendations before they saw the recommendations, which is pretty gutsy of a government, it's still going to take time to put into place. And you know, I've been chastised for saying 10 years. I've been chastised by one of the state premiers for saying, you know, 10 years is too long. I agree, 10 years is too long. But I think I'm being realistic, and I will be the first out there going, yes, I'm wrong if we get these reforms in place and we get the benefits in 4 years or 5 years. But we have to be realistic about time.
So I was very interested in what you're talking about, stigma and also workplaces. And we've got a question from Renata saying, how do we support changing the culture within the current systems, and particularly in workplaces where there still is that stigma?
Yeah. And it is, how do we change social attitudes? And it's a slow process. It again needs government leadership. It needs it actually needs leadership right the way through the community, but we've seen it happen. And we had the justice demonstrations a couple of days ago, and they are an example of people getting out there and changing community attitudes for the better. And I'm not suggesting that you start having demonstrations in front of Parliament House. Maybe it's not a bad idea, but there needs to be pressure for change right across the system. There needs to be, quite frankly, education across the system, because our lack of understanding about mental health in the broader community is shocking. And it's through education and understanding, and by pushing and saying, this is not acceptable, that's how we're going to get change.
So you mentioned the Victorian government accepting the recommendations of the Royal Commission, but are there any indications whether the Australian government will accept and implement what you've put forward?
Look, really, based on the Australian government, unfortunately, they don't tell me. All I can really say is that the reception to the report has been very positive. I think it's pretty clear that the government is moving forward on a number of fronts in terms of mental health reform, and I suspect we'll see in the budget and later on this year some of the fruits of that. And I hope it gathers a momentum so that when the next political crisis comes, it doesn't get pushed off the agenda and it can keep on moving forward. But again, because it's not a political issue, because I think it's clear to pretty much everyone that this matters so much, I think that's the best indicator that we have that progress is going to be made.
And we've got to wrap up, we've got to move on to our panellists, but just before you go, what is, you have obviously put a lot of effort into this report and the commission. What will success look like for you in terms of the fact you've put all this effort into it? What are you looking for to see this report being put into action? What does success look like to say, okay, now we've seen that, that this is actually not just a report on a shelf, but it's actually being put into practice?
Yeah.
What do you want to see from the sector and from governments?
I guess we only ever know success in hindsight. And I think we have to recognise that. We also have to recognise that there isn't just one way forward. And whilst we've come up with what we think are the best recommendations for the government, there was pretty strong internal debate over some of those recommendations and alternatives. So, it doesn't mean that the government says, oh yes, we've got 21 recommendations, 103 action items, and we've done them all. What it does mean, success will be measured if in 5 to 10 years' time, we look back and we say, oh my God, I can't believe we used to do that in 2021. Do you know people in 2021, their mental health is deteriorating, they had to go to an emergency department. No, that alternative to emergency didn't exist. I know every hospital now has an alternative to emergency, a safe area with peer support workers, but that didn't exist in 2021. That's how we'll measure success. And again, it will be from the consumer's perspective. So if consumers in 5 to 10 years' time say, oh, thank goodness, that will be the indicator of success.
Wonderful. Look, thank you so much, Professor King. Wonderful note to end on. We really appreciate your insight and joining us today. And we're going to have a panel discussion now to unpack this report a little bit more. But thank you very much for your time.
Thank you.
So we're going to introduce our panelists now. And I do encourage you in the audience to ask questions. I'm getting the questions on my laptop, so I'll try to get as many asked to our panelists. But the panelists who are going to be joining us, Dr. James Antoniadis, the Chair of the Royal Australian College of GPs, GP and Psychiatry Liaison Committee, Dr. Stephen Carboni, the Director of Prevention United, Dr. Zena Burgess, the CEO of the Australian Psychological Society. You can see them all jumping on one by one. And Catherine Ellis, the CEO of Youth Affairs Council Victoria. So I think we're just waiting for Zena to pop up, and then we'll get going. But it was certainly really interesting hearing there, Zena, hearing that report and hearing the details, and there's a lot in it. So I think what we'll do is sort of unpack things bit by bit. We might start with maybe with primary care and go to Jim. What was your view of the Productivity Commission report when they tackled the issue of primary care? Let's look at that.
You're asking me?
Yes, yeah, let's...
Oh, sorry, you cut out there for a sec, that's why. Look, I think having read the relevant sections, because it's a very big report, both the Mental Health Royal Commission and the Productivity Commissions, what I see is a lot of really good stuff there. There's a lot of information that I think can inform choices going forward in creating a new system. I think we really do need a new system. The old system really is broken, and I think that the Mental Health Victorian Royal Commission highlighted that and admitted that. And I think the problem going forward is, how do you deal with the broken bits? How do you stop them coming back and dominating a system because they already exist, and wiping out new fledgling parts of the system that are trying to take root? And that's my main fear, is that the old system will reassert itself. The two commissions, I think, happened in a timely way. I think it was good that there was a federal and state-based commission running at the same time. Because it's obviously a problem that's going to require state and federal interventions. The fact that the state government looks after hospitals and local services, while the federal government looks after Medicare and some of the bigger funding supplies, I think really means that they need to work together. If you're asking me, there was a couple of questions that were that have been put to the panelists, and so I'd like to just address the primary care. From the primary care point of view, the main concern that I would have is that general practice gets sidelined as a gatekeeper, and there are some possibilities that might happen, particularly with the Productivity Commission seeming to disparage the importance of mental health assessments by GPs, instead saying that it's okay for people to just go online and do an assessment and then sort of refer themselves. While that sounds, very egalitarian, it does take out of the equation a little bit the important relationship that's pre-existing between the GP and the patient. It also tends to depersonalize it a bit, and it also creates a problem with gatekeeping. The fact that for decades psychologists haven't had any sort of rebate and now suddenly they do, creates a problem whereby what was once an underutilized system could easily become an overutilized system, to the point where people in real need might not be able to get in to see a psychologist because they're inundated with self-referred people who maybe didn't need that, or probably would have required some other service that a GP might have been able to point them to.
I might bring you and Zena here just to talk about that, because Professor Professor King did talk about the better access system.
Yes, I enjoyed listening to his comments. I guess the first thing I want to pick up on is his sort of anecdote about his wife's friend and the idea of accountability. Certainly, psychologists do ask their patients and their clients if they're getting what they need from the service that they're receiving, and that's quite common. What isn't common is a reporting of data to a third of another authority. And we have no concern about a better access review, but as Jim mentioned, it needs to look at all of the parties that are part of the Better Access program, which is GPs who provide a really valuable service, not as gatekeepers, but as, if you like, case managers of the person's physical and mental health, because the two things can go hand in hand, psychiatrists, social workers and psychologists. The Better Access program was never designed as a population health program, but what is now needed is a population health program. So we're looking to the review to look at ways to expand the program into something that is valuable for the community. I'd also like to comment on what Jim was saying about this idea that people with who are feeling some anxiety and depression defined as low intensity can go online or do a self-assessment or look up Dr. Google and get what they need. That's not the case at all. It is actually important for people to get the right treatment at the right time. And if they're suffering low intensity and it's not treated well, it'll move up the stream to medium or severe. And if a person sees a psychologist for 4 sessions and the consumer, the patient, is happy and gets good service, so be it. The average...
So you're saying just because they've only had 4 sessions doesn't mean it wasn't worthwhile?
You cannot draw a conclusion that it was bad service or inadequate service.
I guess the only way you would know is if you did have those patient-reported outcome measures.
Absolutely.
Where I had 4 sessions, I felt it was worthwhile and I didn't need any more.
That's right. Yeah. Certainly the average number of sessions is variable, but we find that when people have to return to a GP for a review, that's when they cease to continue, because that's a friction point. But certainly the role of the GP is really important in the Better Access program, as is the partnership between the GP and the psychologist. So I'll stop.
No, you're right. I might bring in Catherine and Stephen as well. So Catherine, just your perspective of the Productivity Commission report, was there enough in it to help the sector that you represent, young people?
Thanks, Sophie. Yes, I think that there were a lot of really interesting findings and recommendations in there which will go towards improving what is a very broken and underfunded system. I think from the perspective of my organisation and the youth sector itself, what is actually missing is a recognition of the role that community organisations and sports and recreation organisations play as part of the mental health system. They're often, because they don't provide clinical services, they're not seen as part of the system, but in actual fact, they are the place where it's easy, schools as well, but schools are focused on learning, not so much the sort of wraparound of that, of health and wellbeing. And there are real opportunities to mobilise the community sector and sports and recreation organisations as a place where young people come universally, where there's no stigma in them being involved in those organisations, and they build trusted relationships with youth workers and with peer workers that provide a trusted pathway, well, provide initial support. And you know, Zena made the very good point that people don't necessarily need to go and get clinical support if they can get other kinds of supports early on. And but then when there are referrals needed, there's a really trusted pathway to those other services that young people will then go to. It also means, you know, for young people who are marginalised in some way, whether it's through poverty or through disability, language, young people of colour, young people in rural and regional areas. There's a lot of ways where young people don't actually have an easy pathway to access the services that do exist in the sort of recognised mental health space. And so being involved in local community organisations can also help with, again, a non-stigmatised, easy access way of finding those services when they need them.
And there's probably some sectors, particularly even within youth, the youth sector, that are more likely to take up those services than go to, say, like wanting to go to their GP or wanting to go to see a psychologist or a psychiatrist. So you want to have that variety of options available, I guess, for people.
Absolutely. And in some cases, it's an affordability issue. Not every young person can afford to go to a GP whenever they want to, or to go and see a psychologist, even if they can get into one, which is always an issue. But in rural and regional areas, the services aren't even there. And the idea that a young person would ask somebody to drive them 2 hours to go somewhere, and the stigma that surrounds that it's a really big ask for a young person, even if they have already identified themselves, which is often not the case, that they need some kind of mental health supports. So there's a lot of sort of complexity in it that is not really recognised, I think, in this report. The other one piece of that is the sort of recommendation around increasing digital services for young people. And there's no doubt that is a really great thing if that can be expanded, particularly for access reasons. What it does need to be combined with, though, is a recognition that a hybrid service is really important. And it comes back to that, developing those trusted relationships, and also recognising, I think when people think of digital services, they think of the sort of well-off middle-class white young person sitting in their own bedroom with their own device, unlimited data, lots of privacy, probably parents are supporting them and brought them a drink before their session with their psychologist. The reality is a lot of young people are living in crowded housing with minimal devices, no data, no privacy, and quite often, a stigma in the community around accessing mental health supports. So we have to recognise that.
So Stephen, I'll bring you in. What was your response to the Productivity Commission inquiry when it comes to prevention? And did you see things you would wanted to see, or what was your sort of key takeaways?
Yeah, look, I guess a few mixed reactions. I mean, I think, the report has got a lot of great recommendations when it comes to the sort of mental health care supports and services for individuals that I guess, in Professor King's words, are above that clinical threshold, the traditional mental health care system, whether that's clinical or psychosocial supports. But I think it touches on, but probably to, in our view, doesn't really go far enough when the conversations about mental well-being and the prevention of mental health conditions. I think there are, some things there that are, touched upon, but I think they're really quite separate. And it's better, in our mind, to think of the mental health system as almost like two integrated components: a public health informed promotion prevention component and a mental health care component that includes all those clinical and non-clinical sort of services. So, yes, the report does talk about, better identification of parents who are struggling with mental health issues or challenges. And that's really important because parental mental ill health does, of course, impact on child development. And that's a form of both early intervention and prevention simultaneously. It also talks about social emotional development of kids and the importance of, early learning services and schools having those SEL programs, those self-care resilience skills building programs, which is great. And then it talks about universities and workplaces as settings to promote good mental health, as well as settings that support people through recovery, from a mental health condition or challenge. So there's some good bits in there, but look, when it comes to then the meaty end, as Professor King talks about, governance and accountability structures and funding mechanisms, there's really no commentary about how we're going to fund and support a greater focus on promotion and prevention. It's all about how we're going to focus on, supporting improvements in the pointy end mental health care system. So I think compared to the Royal Commission report here in Victoria, which goes into much greater detail in Chapter 4 about the difference between prevention and early intervention, they're actually quite different. You prevent skin cancers by slip, slop, slap. You intervene early by detecting changes in moles and cutting them out they're quite different sort of approaches, and prevention and early intervention shouldn't be conflated, nor should mental health and mental ill health. And so I think we need a better functioning mental health or wellbeing system, as well as a better functioning, mental health care system. And I think the Productivity Commission touches on that, but I think there's more meat on the bone in the Royal Commission. I'm not trying to be negative or disparaging of the Commission's work. It's just the way, it's highlighted differently in each of the reports now stands out.
So there was one question that I wanted to ask the panel. It's about the regional commissioning authorities that were talked about in the report, and whether the recommendations around those commissioning authorities and the state and federal cooperation, whether you think that the report sort of really got that right. We might start maybe Zena, you're up on screen. With the regional commissioning authorities, so what was your view about that, and whether you think that's a feasible option?
Look, well, as Catherine was saying, the services need to be responsive to the community, and there are absolute issues in rural and remote and in regional centres as well. So if the regional commissioning authority is going to assist with that, great idea. My confusion is how that sits alongside the PHN, which goes to the core issue of this federal state issue. And it'd be really great if we could untangle that, because once we untangle that, then maybe we'd be able to save some money on administration and put more money into services. My concern is, great idea, but are we going to end up with a state PHN and a federal PHN and more administrative units that then add to the navigation challenges for any consumer?
And maybe Jim and maybe Catherine, did you have a view about the idea of these regional commissioning authorities, whether they are a feasible model?
Yeah, if I might start. Look, yeah, I do have a view. The PHNs are, I think, a good idea, but unfortunately they're way underfunded in order to be able to really make an impact of taking services that are being attracted to the city and drawing them into regional areas. If we are serious about saying that everybody in Australia needs to have the same level of care, then we have to be serious about saying, and we're going to reward people to go out there and supply it. I mean, if you want to buy petrol in the country, you're probably going to pay more for it than petrol in the city. If you want the NBN on a 10,000 hectare farm somewhere out in the bush, it's probably going to cost the supplier more to get the NBN out there than they would at your neighbourhood house. And the government has committed to providing NBN to everybody and pays more to do so for people in rural areas. Unfortunately, the Medicare system as it stands pays the same rebate to a doctor or a psychologist in Melbourne as they do to someone in the country. And if you do that, what's going to happen is, on balance, people are going to say, well, I can probably make a better lifestyle for myself, my family, my wife, and my husband can also get a job in the city. The cost of going out to the country and providing that service is going to be too high to me personally to accept that. So I think we have to get serious about doing something which is a bit of a no-no in the Australian system, and that is having a regionally based differential rebate system whereby we reward people for going into more and more remote areas. And it might not sound...
I know the federal government's announcing a big initiative today about wanting to get people to move to the region. So that's interesting that you bring that up today, because that's something that the government's very keen to do, to get people moving there. But the services need to be there, and you need to have a way of making sure that encouraging people to go there to provide those services.
Yeah, I think the methods that they're trying to use at the moment of establishing universities in the bush and so on are okay, but I think at the end of the day, people decide based on their whole family and future lifestyles. And unfortunately, many people who do get conscripted, whether they're overseas doctors or whatnot, to go out into the bush, well, once they've done their time, most of them end up leaving. And I think that really there needs to be a financial incentive and compensation for staying out there.
And we've had a good question from Amanda from Ballarat Community Health. She says, very regularly we see a huge commitment into early intervention, but what about the huge proportion of mentally unwell people in their mid-30s, 40s and 50s who have multiple complex needs? how do we ensure this age bracket and needs are met effectively? Maybe we'll go to Zena and then and maybe to Stephen. So Zena, how do we make sure that the people in that bracket with complex needs have their needs met? And was there anything in this report that would help that
I
group?
guess, yeah, thank you, Sophie. Look, I see this report as really a philosophical statement of direction. And I think it's a really good one and a sound one. What has to come now is some really hard decisions about the priorities. And regardless of our belief, and we all are committed to every person in Australia having good mental health and good mental wellbeing, there's going to have to be some decisions made. And I think Jim was saying, or was it Stephen, that, you know, whatever happens, it comes back to we end up with more emergency services for the high-end person who presents at ED suicidal. What we need now is an implementation plan for these reports that actually prioritises where the money is going to go and what are the priority groups. And I understand the need for people at all stages to have services, but it's about how they can access those services. So if you imagine it being a project plan, it's got cohorts, consumer input as to what's the best way to access services for those groups. And that includes things that, like Catherine was talking about community organisations. We run a program called Tackle Your Feelings with the AFL, which is about helping coaches to deal with first level emotional issues in their players. So it's about different ways to look at services. If you're looking at that cohort, I'd be looking at services in the workplace and at universities as an intervention point, but it's looking at each of the cohorts, where's the best place for intervention for mental health, but intervention for mental wellbeing as well, and actually writing it up as a plan.
I'd just add to that also, Sophie. I think that people in their 30s, 40s, 50s quite often have actually first exhibited issues in mental health.
Yeah, which Professor King
early
said.
years, exactly. So actually sort of investing in youth mental health is actually part of addressing the older people's issues as well. But I would also add that it's not just about clinical services, and back to the last discussion around, you know, how are we structuring this whole system? If we put all the money in the hands of clinical providers, then we will end up with a clinical system. So we need to make sure that there's diversity in the governing bodies that are making the decisions around what services any community needs and any cohort needs, and making that as efficient and ideally as preventative as possible, so that, which is you know, a much more efficient way of providing mental health services anyways, preventing serious issues in the first place. But part of it also is looking at the social determinants of health. So part of, again, you know, addressing the issues of complex needs of anyone of any age is also looking at, you know, are they living in poverty and why? Are they struggling to access safe, secure housing? Why? Are they experiencing discrimination or abuse in their workplace, in their home life, in the community? How do we stop that? Those kind of things are actually a huge part of addressing mental health issues as well.
Yeah, I'd have to totally agree with that. I mean, I think, and it's disappointing in some ways that, you know, the report doesn't touch on some of the major contributors to mental ill health in the community and what we're doing about them. I mean, trauma, violence against women, as we're seeing at the moment, racism, discrimination. It's very silent on those bigger picture social issues that we need to address, and more really waiting until people become unwell before we step in and do something. You know, that's not good enough, and we really have to be more proactive in tackling the root cause, the underlying risk and protective factors, which then benefit people experiencing recovery as well. And I think that across you know, the Productivity Commission report, as I said, you know, it touches on some of these things, but more at the resilience end and not at the risk end. And I think we really need to get down to a deeper discussion about how to prevent mental health conditions as well as to support people experiencing them.
We've only got about a couple of minutes left, and given the theme of today is putting it all together, because we are dealing with, you know, a number of different reports that have come out, I just wanted to briefly go to each member of the panel and ask them about how does the Productivity Commission, how does their vision of reforms, how will it work in practice with the Royal Commission's vision and recommendations? So Zena, how do you think that the two will slot in together?
We're interpreting it and pushing for the services and focus to be on children and families, schools and workplaces. And if you can tackle those three, and that is looking at some of the social determinant issues, but if you start there, you're tackling some of the prevention, some of the early intervention and some of the treatment.
Wonderful. And Jim, what about you? How do you see these two reports fitting in together and working together to improve mental health care for Australians?
Well, look, I think that looking at countries that are wealthy countries like Australia, they also haven't done well despite being very wealthy. Sweden is worse on the suicide scale than Australia. So I think we have to tackle the issue of how we are a depressogenic society. What is it about Western civilization in Australia, our version of it, that means that people want to kill themselves or get depressed or anxious or have mental illnesses at very high rates, especially when you consider that there are many countries that are far less wealthy than Australia that have much lower suicide rates than us. So I think as a society, we need to tackle that.
Interesting. And Catherine, what about your viewpoint? How do these two reports work together in practice to improve, with the vision and the recommendations to improve outcomes for the sector and for people, with mental health issues and carers and families?
Yeah, just to Jim's point, I think what we also could be looking at for our society is how do we tap into First Nations people's wisdom around health and wellbeing, because there's a lot of richness there that we don't use in our system and we absolutely should be. I think in terms of I think actually the reports are quite complementary in a lot of ways, because some of the gaps that I saw in the Productivity Commission report have been picked up, things around peer workers and peer leadership and lived experience playing a really important role. We're always advocating for young people always being part of the decisions that are being made that affect their lives. Also, the idea of a lot of investment in the sort of wraparound supports for people. So a lot of that was in the Royal Commission report, which was really great to see. And I think that the productivity report, because there's a lot of focus on the sort of the workplace and schools and things, they are quite complementary. And the biggest challenge is really going to be how do we actually decide what are the priorities for rollout and making sure that it's effectively invested in, so that we're not trying to cut corners and do this on a shoestring, because in the private sector, they always talk about spending money to make money. I feel that in this case, if we actually spend money, we can save money. And that's what we need to be looking at doing as we come together as a sector right across all of society and the health system to create a really effective implementation plan that picks up all the pieces at the right moment and invests in them properly.
Good point. Stephen, just finally, before we wrap up.
Yeah, look, I agree. I think they're complementary. I think, the takeouts are invest more, in underlying causes and upstream for younger age groups without abandoning people in their middle years or the older population. You need a strong continuum across the lifespan. But I think the one thing in the Royal Commission that I'd love to see the federal government pick up in its model is the governance arrangements, the establishment of a mental health and wellbeing promotion office, mental health promotion office within the department, and the appointment of a mental health promotion advisor who runs that office and that team, and the implementation of a plan and a dedicated budget for promotion and prevention. They feature in the Victorian Royal Commission report. They don't feature in the Productivity Commission report, and it would be great to see the federal government adopt those particular recommendations, because I think if you've got that infrastructure in place, then it helps leadership, it helps coordination, and it helps to move things along.
And you have a seat at the table when decisions are being made about
totally. And the interdepartmental committees that they've established make sure that it's in a whole of government cross-portfolio approach. So I think they really nailed it in the Royal Commission, and I'd really encourage federal government to look at that particular section and adopt it.
Which is what we said when we had the symposium on the Royal Commission, and we did say that the rest of Australia and the federal sector as well will be looking to that Royal Commission, because there was so many groundbreaking things in it. So look, we've run out of time for this session, but thank you everyone. Thank you Zena and Jim, Catherine and Stephen. It's been a fascinating discussion, really good in-depth sort of look at this Productivity Commission report. It's so detailed, but I think you've given the audience a great understanding of the potential of this report and how it could be implemented. And and with all the different sectors working together to improve outcomes. So thank you all very much for your time. We really appreciate it. We're going to have a short break now, just for about the next 10 minutes. So now would be a great time if you want to stretch your legs, but come back and then jump over to the link to look at the exhibition halls. You can see the exhibitor hall in your program. You'll see the link to that. And it's a great chance to just go and have a look at the sponsors. You can see them on the slide that's up at the moment. But stretch your legs, grab some tea or coffee, and we'll be back. We're just going to have a short break. So we'll be back at 5 minutes to 11. We'll see you then. Welcome back, everybody. It's been a great session so far. We've got some really amazing speakers coming up and some panel discussions. So I do encourage you to keep asking questions and putting it out on social media. If you're on Twitter or Instagram, don't forget it's @mentalhealthvic, and mine is @SophieScottman2, and the hashtag is putting it all together. So we're absolutely delighted to introduce our next guest. The key plank of mental health reform in Australia is the commitment to reducing suicide rates. And part of that commitment was appointing Christine Morgan, the CEO of the National Mental Health Commission, as the National Suicide Prevention Advisor to the federal government. Christine is a passionate leader in mental health care reform, and she came to prominence, and that I got to know Christine when she was the CEO of the Butterfly Foundation for Eating Disorders and the National Director of the National Eating Disorders Collaboration. And she's now doing some amazing work in mental health nationally, and also in this important role advising the federal government on suicide prevention. So as I said, there will be the chance to ask Christine some questions, so please be thinking about the questions that you might have for her. And now it's my pleasure to welcome Christine Morgan to talk about the Vision 2030 report and the National Suicide Prevention Strategy. Welcome, Christine.
Sophie, hi, good morning. Now, can you hear me okay? I'm hoping I'm coming through okay for everybody, and thank you so much for this opportunity to participate in this, this symposium today. It's one I've been very much looking forward to. I do have some slides that I will share, but before I will do so, I would just like to acknowledge and pay my respects to the traditional custodians. That's me speeding up too much this morning, slow down. The traditional custodians of the lands upon which all of us are meeting. Here in Sydney, where I am today, it's the Gallagher people, and to pay my respects to their elders, past, present, and emerging. I would also like to stop and remember and pay my respects to all of those who have walked the journey of mental illness, of mental ill health, those who have cared for them, and those who have walked the journey of suicide, and to pay my respects to all who are involved in this sector. That includes you. So thank you. And look, perhaps we can start with sharing the screen from here. So just bear with me and I'll make sure and we'll just go into slides. Fantastic, thank you. So what I would like to be talking with you about today is the mental health reform agenda that is now very much part of our reality, and trying to do this from a national perspective. So I was really going to try and outline it for you from that perspective itself. I know that in Victoria, you have had very recently the release of the Victorian Royal Commission report, which is a fantastic report. There are many touch points with that report, with what is happening at the national perspective. But I think given the fact the mental health reform agenda is one that is covering all jurisdictions in Australia, this is the opportunity to potentially put it from that perspective. And I'd be very happy to take your questions from that side as well. So what I was really wanting to start with, I guess, is to look at the fact that there have been a number of key reports that have been commissioned. These days, I frequently talk about the fact that we're kind of coming into things for the mental health reform agenda here in the first half of 2021 with the outcomes of a number of reports which were commissioned a number of years ago now, pre that cataclysmic year we all went through in 2020. COVID-19 has changed, I believe, the way mental health is talked about in Australia and internationally. It has provided, I think, more of an enabling platform And it is an interesting lens through which to go to get to where we are to in the mental health reform agenda here and now in March 2021. But I think it is important for us to remember that the instigators, the pioneers for where we're currently sitting with mental health reform in Australia have been there for some years. And there are effectively 4 key reports where I've looked to say, how can we try and synthesize these down and actually understand the common touch points for all of them? That actually wasn't such a difficult exercise to do. And I just want to talk us through these 6 strong themes which have emerged from each of those 4 key reports that you can see on the left-hand side of the screen. The Productivity Commission report, which was effectively a line of inquiry that looked at what is happening in our mental health system in Australia, what are the issues with that mental health system, and most specifically with a lens of what is the economic impact and consequence of that. And I think that you've already heard from Stephen King do his great presentation on the findings of that seminal piece of work. And as he would have said to you, it has proven to be the largest inquiry that the Productivity Commission has ever done. Thanks to many of you for the submissions that were provided to it. Secondly, as Sophie referenced in her introduction, I have had the opportunity, and it's been such a pleasure and such a privilege really to work alongside many people who have gone through the reality of suicide, suicidal risk, suicidal behaviour, to actually understand what is and is not working at the moment. And it's fair to say we have unacceptably high rates and numbers of suicide and suicide attempts in Australia. So the suicide prevention advice, we'll talk to you today about the advice from the perspective of the interim report, which was released by the Prime Minister in November. The final report has been handed into the Prime Minister, but without any substantive significant differences. So I'll be talking to you from that advice perspective. We, of course, have the Victorian Royal Commission report, and then some seminal work that we have been doing in the Commission on Vision 2030. And I know, again, many of you have contributed to that. And the Vision 2030 blueprint effectively came from the Minister asking us to say, Chris, what would it look like if we got to 2030 and all of it was working properly? What would that look like, and what would be the experience for people? So I'll take you through those in some detail. But the interesting thing for me was the fact that we can actually, when you look at those 4 reports, draw through 6 very clear themes for mental health reform. And to me, this underpins clarity of the way forward. And I think we're going to be looking at mental health reform not just in this first budget in May, but I think we have got a road ahead. So looking at it from this theme perspective, hopefully will give us an ability to look at the various touch points for each of those roads, whether it be from a Commonwealth perspective, a state or territory perspective, such as Victoria, or indeed a national perspective. The single most important thing that we have heard about is accessibility to the system. Yes, that means geographical accessibility, but one of the biggest barriers that people experience is affordability and being able to access services they need and to be able to find them in an affordable way. So that is a very key factor. If people can't access the services, then it doesn't matter how good the system is, that's not going to actually take them to that point of sustainable recovery that we need. But as we've noted there, it's also accessibility also means I will find those services that are accessible to me, the person. So what are the specific need of key groups that we have? I want to leap there. I'm not going to go around in a chronological order because I want to leap there to what I regard still, and having come through the last 18 months, 2 years, I think I'm even more firmly of this view than I was back in my butterfly days, which is of the criticality of lived experience actually driving what we do in our mental health and suicide prevention systems. It is absolutely not appropriate that we just use lived experience to illustrate points that the experts want to make. And I think that's been particularly the case in suicide prevention. We actually must absolutely embed lived experience. And I'm so firmly of that view with mental health because, as we all know, our mental health must be expressed by us from an individual perspective. It's an experiential thing, not something that's defined by a list of clinical symptoms. And unless we can actually embed that approach in our system and embrace that as part of our reform, we will just be doing a Band-Aid approach. So that, I think, is the most critical thing we can possibly hold on to. Early intervention, to me, early intervention is certainly early in life. It's early in experiences of distress. If you're looking at it from a suicide prevention perspective, it's early in illness and it's early in episode of illness. The evidence just leaves no doubt that getting in early and being able to provide supports and services for people at an early stage makes a fundamental difference. And that was certainly a key thing that came through in the Productivity Commission report. Effectively, what the Commissioner said there is we have got too many people coming into the system when they are really ill. It's not efficient or effective for the system, and it certainly is impeding in a very costly way on their capacity to live a contributing life. Integrated and coordinated services, I think that is probably just an absolute given that each and every report has looked at. We have a fragmented system. Some people talk about duplication. Yes, to some extent that is there, but without a doubt, we have a fragmented system. It's fragmented in terms of how we provide our mental health services. We actually need to integrate those. We need to coordinate them, but we also need to remember mental health exists alongside and with and is impacted on and impacts our physical health. And we need to look at how it integrates with our psychosocial supports. Workplace and workforce. Both W's are incredibly important. I will talk later about one of the findings, particularly from, I think, our COVID-19 year, which is about the importance of places where we work and the impact that has on our social connectedness and our ability to be reaching out to each other. The need for us to be integrating and coordinating our services, I think another very strong enabler that we must put a deep lens on and we must solve this is how do we actually ensure we have the multidisciplinary workforce, including our peers, that will enable us to implement and deliver on all of this reform. Otherwise, it will be a theoretical exercise. And finally, we need to be driven by outcomes, not outputs. So we have a system which is embedded in our health system, which looks very much at activity within the system. How many people are using it and when? For our mental health reform agenda, we absolutely need to pivot away to outcomes. And I'll have a slide that goes into that in more detail. So looking at the two pieces that I would like to talk to in particular, which is our Vision 2030 and then the suicide prevention advice. Vision 2030 was effectively based upon a lot of conversations and consultations with people. It was articulated late 2019, early 2020. And we spent 2020 doing a lot of work to say, what does this look like in terms of what we need to do to change the system? We called it a roadmap piece of work. And again, a number of you were involved with us. Getting to the end of 2020, and recognising the willingness of all governments to embrace our mental health reform agenda, we've consciously now reframed it as being a blueprint that can be a place of knowledge, a place of resources that can inform the mental health agenda. It aligns across, as I've said, with every one of those other significant reports that have come through. I think the most important thing, if I had to encapsulate it, what we're really wanting for a system that is delivering what people need is that it provides coordinated, and you won't find these words on that page, but I would call it, we want coordinated, navigable, multidisciplinary care for anybody in Australia when they need it, where they need it, in a way they can afford, and for as long as they need it. And it must be person-led. Others will hear me talking about the fact now that I think it is well recognised in Australia that we have a universal health system that is really quite admired internationally. Why can't we do that for our mental health as well? That's the aspiration. The specific outcome that you can see there on the slide is that every person is supported to be mentally well and live a contributing life within a system that invests in prevention, early intervention, and the addressing of social and emotional wellbeing as a whole. unbundling that a little bit, I think the importance here is saying, let's really focus on mental wellness. And for those who have the challenges of ongoing illness, let that not define them. Rather, that let us put a focus on how do we provide supports for them to live as fully as they would choose a contributing life. I think that is an incredibly important focus. To do that, we must look at prevention and early intervention, and we must look at the social and emotional context in which we exist as human beings. The blueprint is broken down into 4 key components, and some of you will be familiar with a much more detailed slide than this, which we can make available, of what is actually bundled into each of these kind of particular areas. But in order to effect the change that we need to the system, we found it useful to look at, okay, what are those governance structures that we need? And I'll talk to a couple of those in a bit more detail. What are the performance enablers? What are our components of care? And what are the delivery mediums that we need to be addressing? When you look at your governance structures, I think here, this is the kind of leading from the top. And it's saying, what do we actually need to do to ensure that we have got national structures that provide clarity as to who in the system is doing what? What do we need to ensure that we've got consistency across the system, so that irrespective of where you live in Australia, irrespective of your demographics of your kind of circumstances, you will get quality care that is evidence-based and appropriate for your needs. And the real challenge that we have is, how does that translate down into local solutions? And I think this is probably systemically one of the real challenges that we have. How do we get that clarity at a national level? Well, I think there's been some strong commitments made by National Cabinet, and it's being implemented this year for a 5-year national mental health and suicide prevention agreement between the Commonwealth and the states and territories. That must be delivered. It has a time frame of November of this year, and at a minimum, it needs to provide clarity as to who's doing what in the system, who's paying for what. We have, as we all know, at the moment, this very messy, I'm going to call it again, fragmented system, where Commonwealth does primary care, where states and territories do tertiary care, and the vast majority of what we do in mental health, which is our community-based care, is just a melting pot that everybody participates in with no clarity. And I'll come back to that again with our core components of care. Second thing that we need, so we need that national agreement under our governance structures. We also need, I believe, under our governance structures, national standards and agreement as to national outcomes. Those standards of care are ones we're beginning to talk about with the chief psychiatrists and others around the country. We have to understand, what is it that we are looking to achieve in terms of standards of care for right across our mental health services, and how do we measure them in terms of national outcomes? So I think that is a particularly challenging thing for us to do. The third thing, and this is, as I say, just cherry picking a few things from this column of governance structures. The third thing is, how do we get the challenge of national agreement that translates down from the Commonwealth down through and with the states and territories, and then most importantly gets translated into localised need? Because it's in our, if by definition we're wanting to deliver care in our communities, then we have localised needs. How the heck we do that within the system is the challenge that we need to implement. If I come across to our performance enablers, this is incredibly important as well. What do we need to have in place to ensure that we can actually do the service delivery in a different way? That would cover things such as our workforce. And I'll keep coming back to it, our multidisciplinary workforce. One of the challenges we had throughout 2020 was not a lack of agility in terms of responding to mental health needs at a policy level, or even indeed, welcomely, at a funding level. The single biggest challenge we had was workforce. So we need to grapple with this. We need to grapple with, what are the disciplines that need to be in the workforce for mental health, and how do we ensure not only that we're enabling them at the moment, but have a pipeline coming through. Now, there's a lot of work that's going on at the Commonwealth level and in the states and territories about workforce, My own personal view is that we have to sharpen the pen on this one. If there's anything we need to collectively come together and do better, it is very much around workforce capacity, workforce capability, and workforce pipeline. And front and centre of that work has to be our peer workers. And that needs to not be tinkering on the edges, but really bringing our peer workers in so they're a fully functioning and critical component of our workforce. So workforce is one. A couple of others that come to mind under performance enablers is data. We need research and data. And we saw that in our pandemic mental health and wellbeing response plan. There was a consensus across all of the states and territories and Commonwealth. We need to get better at not only collecting data, so our surveys need to go a lot deeper than they currently do. We need to be able to share that data, collate the data, analyse the data, use the data to inform us in what we need. We also, I think, under performance enablers, if we want to address that question of accessibility and affordability, we need to be looking at what are the funding models which will ensure that we are delivering the services in a way that people can access and afford. We then come across to the core components of care. And this is one which I think sits fairly and squarely in what we call a balanced community-based approach. That was just stumbling a little bit over that, community-based approach to the delivery of mental health services. Across the country, there is broad consensus that we want services delivered in community as much as we possibly can. What we want to avoid is postcode shopping. What we want to avoid is I can either get that service or not because I've had somebody who's been advocating for that particular type of service in this particular setting, so I've got access to it and others don't. We need clarity as to what are the core components of care. What should I be able to expect in terms of general services, in terms of specific psychosocial support services, in terms of psychotherapy services, whether that be intensive for myself or group ones. What are those core components of care? And once we've got clarity on those core components of care and they are defined in the blueprint, who's going to do what? How do we best share those between the Commonwealth, between states and territories? How do we make sure they are all going to be funded and delivered? I think that's an incredibly big piece of work there if we're going to have an equitable, accessible system for all. And we also need to look at how we coordinate across those different core components of care. And then we need to look at our delivery mediums and how and where are we delivering them. There's a lot of talk at the moment, and this comes up in the Victorian Royal Commission report as well. It's come up in work we've done in the Commission around the child mental health and wellbeing strategy. It's coming up in work that's being done around regional and remote, and that is the concept of hubs and co-location. How can we actually make things accessible? I actually want to go one step further and say one of the biggest learnings from 2020 during COVID was the realisation that we must actually make sure we're making services accessible for those settings in which people live, those settings in which people work, those settings in which people learn. So how do we make sure that the services are, again, it's an accessibility issue, are being delivered in the right settings to reach people from a prevention and early intervention space, which could be our education settings? How are we using things such as telehealth and digital in a way that provides the best outcomes for people? The final thing I'd say about the blueprint is it's based upon core principles that have been well canvassed with many, many people who've contributed to Vision 2030. You will see again, we lead with lived experience. That is a fundamental underpinning principle which must feature at any point of reform. Then we look at partnerships and collaboration, community-based I've talked about, flexibility of solutions. I think we now are very much in that place of what can we do? Innovation, best practice, recovery-oriented. How can we ensure that people have sustainable recovery? Trauma-informed, equity and equality, and through the lens of what, after all, are our human rights. Coming then to the suicide prevention advice. What were the observations from the suicide prevention advice? Well, as I say, what is up on the screen there is the three reports which effectively formed the interim advice, which was published in November. The final advice has taken a very similar approach. There is a fourth document in the final one, which is called the kind of the overarching summary, and the interim advice now reads final advice. The interim advice had 13 in-principle recommendations, which we have canvassed broadly with people. They've now reduced down to 8 final recommendations, but they are very much aligned to the 13. I will talk in a moment about how we actually structured that advice, and in fact, I will start with it because I think it then leads to what those 5 dot points are that really represent, I think, some shifts that we need to do. The first thing that we did was in the back end of 2019, look at our initial findings. And it became apparent, even in those first couple of months, that particularly in the area of suicide prevention, the involvement of lived experience was far too frequently, please come and help us illustrate a point that we're wanting to make, as distinct from really driving any changes and shaping our service delivery. So it was incredibly important to us that before we did that deep dive into, say, what are the system changes, that we better try and understand just what it is that people who are going through suicidal ideation, experiencing suicidal behaviour, experiencing suicidal distress and crisis, what is happening for them. And also from the perspective of carers and families who had lost somebody to suicide. And what was really interesting is I think that they are 2 very clearly different but aligned and important and critical lines of inquiry. What is the experience for myself if I'm going down that pathway towards suicidal crisis? What is the experience for my family if I've lost somebody to suicide? We can't assume that they are one and the same. We don't assume it any longer. We need to have both voices. What we tried to do with Compassion First was to actually say, let's go and talk to those people, as I said, who have experienced this firsthand. And let's ask them 2 questions. One, tell us about your journey. What for you is your journey? Help us better understand it. And then secondly, what was your experience of the system as you were going through it? What we found, and we had an opportunity of working with close to 2,000 people, and I think this is now really fired me up at least to say we must continue this conversation with people because it was so fruitful and enlightening. It reinforced the fact that you cannot say there is one pathway to suicide. You cannot say that. Everybody has an individual pathway. But by looking at those stories that were shared with us and doing a thematic analysis of it, J.L.E. Scan, who was a critical person behind this, working with MIF and others across the sector, was able to identify some what we would lightly call themed journeys for people that are starting to help us understand a little bit better what are those journeys for people, because one of the most significant shifts we need to make, and it comes to this word seismic shift, is that our current system is very much focusing in on suicide prevention when crisis is happening. I actually call that clinical intervention. If we truly want to make a difference to suicide prevention in Australia, if we want to reduce the number of people we're losing, and most importantly, also reduce the number of people who are attempting and going through crisis, we must better understand what are those journeys, those pathways, and we need to intervene as early as we possibly can. And that has coined the phrase that I now use, which is to say that coming out of this advice is to ask us to fully embrace suicide prevention, to maintain the emphasis on our clinical interventions, but also to start introducing what we call targeted distress interventions, to recognise that the pathway to suicide starts for many very early in life, that it's impacted by the social determinants, things like our financial security, our job security, our housing security, our food security, whether we have incidences of childhood adversity, trauma, discrimination. Those are the types of issues we need to identify, and that's where we need to intervene. That is what talking to people with lived experience has shown us and has led us in our interim advice to say we must have a seismic shift. And I call it seismic because it does actually mean we need to move out of delivery of just clinical interventions into what are those targeted distress interventions that will actually make a difference for somebody at a point of distress. So if I take, for instance, economic insecurity, which may arise around somebody losing their job, without a doubt, there will be heightened psychological distress at that point in time. There is a need for mental health service intervention to support that person. But if you really want to address the distress, which is the economic insecurity that is arising from somebody losing their job and other circumstances, mental health services can't solve that. That must be solved by those skills which sit in different parts of government. So that immediately says we need a whole of government approach. We also need to ensure that across different service touch points, we actually have a more skilled and a more compassionate approach to identifying and managing distress, because distress is a precursor to subsequent suicidal crisis. So how we actually identify and respond to suicidal distress, how do we actually contain it? How do we engage with it? How do we unbundle it? How do we work with it? And how do we solve it? If we can actually do that bit, then that will ensure that we have fewer people moving down that trajectory towards crisis, attempt, and unfortunate death. That will involve us shifting public representation and discussion around suicide. Stigma is still alive and well. I think 2020 helped normalise the discussion around mental health. In fact, it also normalised the fact that mental health and suicide ideation is a very common component for many of us. Mental ill health, is a common thing for many of us, but there's still stigma, and we need to ensure that we continue to focus on reducing that. We need to amp up the public representation and discussion around suicide, and we need to help people understand that this is a consequence of a lot of stresses, a lot of distresses in people's lives. We all go through that. So let's get alongside and help people at that point. So let's kind of broaden, if you like, the understanding of talking about suicide. That brings us without a shadow of a doubt into lived experience. You've heard me say that. I don't think I need to repeat it again, but I will repeat it because it is so critical. The second thing that Compassion First told us very starkly when we were asked the question about what is it like to experience the system is that people came up very strongly and said, we hate being medicalised. We hate being problematized. Don't make us a problem to solve. Be compassionate, be understanding, get alongside us. And that is, I think, a critical seismic shift we need to make. The shifting the focus report that is there is that we, as soon as we landed on the spot of saying you need a whole of government approach, we had to recognise the fact that if I was going into the Justice Department or into social services, they're probably not going to understand suicide prevention. So the shifting the focus is effectively a compendium which talks about unbundling what is suicidal behaviour, why is it relevant to me as a portfolio that is not mental health, what can I do? It includes a decision-making tool for portfolios to work with. I'll speed up a little bit here because I'm just seeing how time is going by. This second slide in relation to the advice effectively captures what I'm seeing as being needed in the reform space. And I want to acknowledge here a very dear person with lived experience who helped me understand that this slide needs to be represented in this way, because when I was doing the final advice, I was actually looking at what are the shifts that we need to do. And then I had the enablers. This very dear person was totally persuasive in saying to me, Chris, don't you have that round the wrong way? Because unless you get your enablers right, you can't do the shifts. Thank you to that person. They know who they are. Thank you. I acknowledge you. And that is the criticality of listening to lived experience, can I assure you. So a lot of this bears a commonality with what we talked about in Vision 2030, what the PC report has said, and what the Victorian Royal Commission is talking about. You need leadership and governance. We need, in suicide prevention, I totally believe, the authorisation of, I've just lost my slides. Can they come up again? Let me see if I can bring them up again. Hopefully they are still coming through. Thank you. We need the leadership and governance of First Ministers. They must authorise, because the most that a health minister can do is to try to persuade his or her colleagues. We actually need First Minister's authorising it. We must have lived experience informing us and central to shaping what we are doing. We need the data and evidence, and can I say in suicide prevention, we need much more data than just those we are losing to suicide. We must have data around attempts and self-harm. We need workforce and community capability to understand and engage with people in distress. In terms of our responding earlier to distress, we need to ensure that we are addressing those social determinants, our economic and other insecurities and stresses. We need to ensure that services are compassionate and providing people with what they need. We need to understand that there are certain groups who have certain forms of discrimination, etc., which are really significantly impacting on their risk for suicide, and we need to address that. And we need to, I think, step proactively into the space of policy in advance. What can we do to make our places more safe so that we don't create those stresses in the first place? I'll touch briefly on this slide and then I'm at the end. This slide says we must move from outputs to outcomes. I talked about that at the beginning, and we need to be looking at what are those outcomes that we need to identify and find indicators, lead and lag indicators to measure. We know that healthy communities has an impact on healthy individuals, and we need a healthy mental health services system. So we need to look at those things which help us in our community to understand and address the full social context so everyone is supported to be mentally well. For healthy individuals, that embraces the concept of a healthy contributing life. And for a healthy system, it needs to be consumer-led. It needs to be accessible, as I've talked about, coordinated and compassionate. So getting to the last slide.
I think we might have just lost your slides again. I might just get you to try to share your screen if you can.
Okay, let me just see if I
love technology.
It's not doing it, is it?
That's okay. We can. We might get a copy of your slides, and if anyone wants a copy of them, we can make them available to
I'm so sorry about this. Let me just see. I can't even see. They're not coming up here. You can't see those. I've got them here.
No, we don't seem to be seeing them, but that's okay. If anyone will get a copy of your slide.
Let me just see. Let me just see if this does it. They come up now?
Now we've got them again. Yeah.
Okay. So let me quickly, Sophie, and I know I'm running a little bit out of time. So did people see that one about the suicide prevention advice?
No. So we saw the key enablers and the key shifts. Maybe if you can move to that one. We saw that one. And we've seen that one.
That one?
That was the last one we saw before.
Okay. And then the one I've just quickly flicked through in the interest of time is this outcomes for all Australians. I think this is a key way. Interestingly, this maps back against Vision 2030, it maps back against the suicide prevention advice, and it maps back against the PC report and the Vic Royal Commission one. And then just quickly bringing it all together, I think there are clearly those three key things. I think the lived experience expertise is needed because it's only people with lived experiences who can tell us how we can improve accessibility and outcomes. The integrated and coordinated system will ensure that we are bringing or making accessible care to people as early as possible. And in this whole complexity of reform, it's very multifaceted, but each of those factors, I do believe, complements each other. So we need to bring it together into a sustainable way. So that's a little bit of a skating through to the end there, Sophie, and I think probably best for me to stop there. And I'll stop the sharing and just come back onto the screen in case there's any questions that people may have.
Yes, look, we've had a couple of questions. I just wanted to briefly ask you, what's been the reaction to both the vision and strategy for 2030 and the suicide prevention advice? What's been the response?
So from a government response, certainly from a suicide prevention advice, it was a conscious decision of our Prime Minister to say that he wanted to release the Productivity Commission report and the suicide prevention advice personally and at the same time. That was his making of a commitment in terms of we will respond to this, and then opening up an opportunity for myself as well as Stephen King to actually address the National Federation Reform Council on both of those reports. So certainly from a government perspective, they have been embraced and we're waiting for the formal responses. In terms of sector response, and I think it will be interesting for the panel that may come after this to talk about it, but I think the sense of engagement we've had with people is that we're finally hearing and listening to the fact that the mental health system is something to be experienced. It's got to be, we've got to look at it not just from what are the bits and pieces we've got to structure in it, and this is Vision 2030, but how do we do it in a way that delivers the experience that people need? So I think that does seem to be resonating with people, and certainly the engagement with lived experience is really critical, Sophie, and I think that might be being heard by people as well, we hope.
And when you mentioned the government response, when are you expecting, or when should we expect that we'll get some feedback from the government about implementing some of the ideas that you put forward, both in the vision and also in the suicide prevention advice?
Well, look, so I think in terms of the vision is feeding into the mental health reform agenda. So we're trying to populate it broadly, underpinning the responses. Look, I can only, as I say, go by what the Prime Minister did commit to, and what he committed to in November 16th, I think it was, if anyone wants to Google it. He did actually say, we will respond in the May budget to both the Productivity Commission report and the suicide prevention advice. He acknowledged that it would not be a one and only response, that reform must be done over a period of time. And then the commitments from a national cabinet perspective that were just before Christmas was to the delivery of this national agreement for suicide prevention and mental health by November this year. So there's been a strong public commitment to doing this. I think probably the May budget is going to be an opportunity to see what that looks like.
Are there some key things that you would be looking for in the budget that you would like to see? Are there that you would sort of highlight as things that you would be hopeful that we should, would see in that budget when it comes to suicide prevention and the Vision 2030?
Look, certainly from the suicide prevention side, those things which would continue to cement recognition that we need a whole of government approach. I think that's what I would be looking for. I think there are so many different touch points, but if we could get those things which would look at how can we actually do this from a whole of government approach that recognises the importance of intervening in distress settings, not just in clinical interventions, and without taking the foot off the pedal for clinical interventions. So, for instance, the Productivity Commission is really keen on aftercare. We would totally support that. So looking at that spectrum, in terms of the Vision 2030 leading into the Productivity Commission response, I think I'd go back to that first slide of mine, which talked about those 6 themes. And I'd be really interested to see, is there anything emerging in May which enables us to say those key thematic areas are starting to be addressed?
What do you think are some of the challenges and enablers of getting the different reform processes to working together to achieve this shared vision that you've outlined in both reports, really?
Look, probably if you'd asked me that question last year, I would have gone, I'm tearing my hair out. How does it all work together? The really interesting thing, Sophie, and the really, I think, warming thing about this, and I think it is due to everybody being prepared over the last couple of years to really contribute to the lines of inquiry with whatever format that has been, RCs, PCs, vision. It means we are all landing in a spot where those common themes can be identified, where I don't think we're in a spot where there is what I would call any chasms of disagreement between any of these reports that are coming out. They all appropriately are looking at it from a different perspective, so all nuanced in a different way, but I think all are saying we want consumer, person-centred, person-led. We're all saying we want to get a form of coordination across this fragmented system we have. We want to know who's doing what. We want to make sure it's affordable. We want to make sure that as much as possible it's being delivered in community-based settings. And most importantly, let's really start to embed what it means by lived experience, certainly in our peer workforce, but more broadly than that as well. So I think all are recognising that, all are recognising this is about an experience and you have to do mental health through that experience, and all are recognising we actually need to make that very important shift away from talking about how much are we spending on mental illness to how much are we investing in mental health and wellbeing. So the commitment to a wellbeing approach, which brings in prevention, is another thing everybody's agreeing on.
So you mentioned, it was interesting when you were talking about the themed journeys, and we have had a couple of questions about from people about how do they share their journey if they still want to. Is there still an opportunity for people if they wanted to get in touch or to give you their experience? So what's the best way for people to do that?
Look, I think at this point in time, if they would still like, I'm still officially in the role of the National Suicide Prevention Advisor. So that is pleasing in the sense that I can still participate in that. The piece of work that we did for Compassion First, and then I should have mentioned, we amplified it for Compassion First version for the final advice by including specifically some further work we hadn't had time to do earlier, which included from the perspective of families and carers and other groups. I certainly want to keep hearing those stories. I think at this point in time, reach out and connect to me either through the suicide prevention line or directly with myself at the Commission. At the moment in time, it's about collecting stories, but I would like people to hear from me, and this is a commitment I certainly make from both of those perspectives. Hearing stories to really fundamentally inform us is critical. I think you and I worked on this, Sophie, when I was a Butterfly, and understanding that some of those real changes for eating disorders had to come fundamentally from hearing stories from people. That's right across the mental health perspective.
Definitely, and hearing stories, you know, even though people's experiences might be different, that there are some similarities, like you were talking about the themed journeys. So even though people might be on different paths, there are some things that are so similar in what they go through that you can then identify what needs to change so that other people can benefit in the future and don't go through the same thing.
I think it's going to be a really important emerging area of research, which is how do we take different stories and how do we respectfully, forensically, and rigorously mine those for those thematic things which need to influence our policy formulation, our service formulation. I think that is an important use of stories. There's many uses of stories. Stories must also be used to illustrate, because it's only by illustrating that we can help others understand. But there is this specific area of research that I'm really beginning to see the value of, which is to say the compilation of stories and the thematic analysis of them can really expose some gems when it comes to what does that mean in terms of conceptualization of services and policies and implementation and delivery.
And that's also very empowering too for the audience and the sector to hear that their stories really do matter, and that you do want to hear them, and that it really will be informing policy and informing these important documents, because I think that's you know, when people are thinking about what they've been through, if they can put it in writing and share their story, it means that they can feel that it's making a difference to helping other people in their path in the future. But look, we could keep talking to you all day, but I'm mindful you probably have other commitments. So look, thank you so much for your time. We really appreciate it. Great to see you again, and keep up all your amazing work. It's been great to see everything you've been doing, and we look forward to talking to you again soon. So thank you very much, Christine. We're going to have a panel discussion now, where we're going to talk through more of Christine's amazing reports and the work that she's been doing. So this is also an opportunity for you in the audience as well to, if you've got questions, we're going to unpack a bit more of Vision 2030 and the National Suicide Prevention Strategy. I'll introduce our panel, but I'll start off by giving unfortunately an apology. Tina Hogarth-Clark, the CEO of Council on the Aged in Victoria, is unfortunately sending an apology. She has had a family emergency, and I know she would love to have been here, but unfortunately she can't be. But we're very well served by our other panelists, who are all just jumping on one by one. We've got Ingrid Ozols, AM, the chair of Lived Experience Advisory Group for Mental Health Victoria, Daniel Bolger, an advisor for the Lived Experience Mental Health Victoria, and Professor Jayashri Kulkarni, AM, from Women's Mental Health Alliance. Thank you, everyone, and welcome. As I said in the audience, please come get your questions through. I've got my laptop here and I'm getting them all coming through. We'll try to get through as many of them as we can. But I thought I'd just start by asking the panelists to talk about, now I might just get people to turn their microphones down a little bit. We're getting a little bit of feedback from someone. How does the vision articulated it might be, yeah, if you can all just turn your microphones down a little bit. How does the vision articulated in Vision 2030 match your vision for what a mental health system should look like? Maybe we start with Jayashri.
Thanks very much, Sophie, and I'm delighted to be here. I do know some of the panel members, not everyone, but thank you for inviting me. So first of all, I think that, like many people have said, it's overdue that the mental health system have reform, and the particular work that's been done by many people is wonderful to see that there is an appetite for reform. I guess in some ways, though, I'm speaking about a specific issue at this point, which is the effect or the changes or impact that's needed for women. And I can speak about other angles because I wear many different hats, but this is in particular talking about women. And I have to say that women's mental health has not received the specialty status in systems to date, and a lot of things have really gone astray as a result of that. We still note that, unfortunately, women are a big group, and even the biggest group in terms of people receiving mental health care. And over the years, I've particularly been very concerned about the fate of many women who experience assaults in the inpatient units when they're actually going there for treatment, often vulnerable before getting to the care providing system, and then have experienced various verbal, physical, and even sexual traumas. So this is the extreme end of it. We look at other ends of it, which is, where are the services for perinatal services for women who've had children, had babies, and what happens there? Where is the particular considerations for people who are vulnerable because of traumas? And I think it's really important and timely. Women's issues are on the top of a lot of lists at the moment, and I think that the reform that's sort of laid out in this document might hint at that, but we would have liked to have seen perhaps stronger language in the recommendation. So, for example, there is a section specifically, if we look at one issue, and there's many issues, but if we look at one issue of safety on the inpatient units, there is a specific area that's described in the big report. But if you look at the recommendations, I can't remember which number it was, but it's 50 something or whatever, the language in that recommendation is very soft. And so that is for me an example of, perhaps there's an appetite for reform, and let's take just this one issue, but it might lose translation. And if the dollars get tight, then this may be one of the things that misses out. And so that's an example. So total big tick for the reform move, the commissioner's work, and all of the people who've contributed to it. But I guess I am sitting here with now a bit of a breath being held to see how it all translates. And I also haven't got a good picture in my head from all of that I've read in the Commission's report as to what the new system is going to really look like. And of course, the devil will be in the detail, but there's some, and I can go on, but I will stop talking now.
No, that's right. We'll come back to you. And I'm just keen to get, we'll go to Ingrid and then to Daniel. So Ingrid, from your point of view, how does the vision that in this particular Vision 2030 and the suicide prevention advice, how does that align with the vision of a mental health system that you would like to see with the focus on lived experience?
Given I am representing the lived experience and have actually been living a life managing my own suicidality and suicidal ideation, have attempted several times to take my life. I've also been a carer of immediate family members who have also been in similar situations, and I've also been bereaved. So I'm sort of coming from very different perspectives, but again, as Christine mentioned, there are some alignments in those experiences. But Vision 2030 and all of the reports that have come through recently build on the reports that have been going out there for years and years and years. And we have been hearing the same sad, tragic stories for way too long. And my challenge is from being the cynic to wanting to stay in my hope bubble that this really will be a pivotal watershed moment in which the rhetoric of lived experience being at the centre of everything actually becomes the reality, and that we can implement and develop relationships, which is key to being able to work together as different perspectives coming to the table of the sector and the community, so that we can bring about the contributions to people who need it, who need our help, where they are, wherever they are, whenever they need it. We don't become distressed between the hours of 9 a.m. and 5 p.m. And yet there are times when we can't access help, and that's been discussed before. So all of these reports to me bring together an opportunity to say lived experience has to be taken seriously. And we're no longer just an add-on or a ticker box, we're part of the solution. And I'm actually really delighted to add in that there was another announcement yesterday from the National Mental Health Commission, and it's so symbolic and brings in together all of these things. The Mental Health Commission has welcomed that the Commonwealth government is giving another $10 million to actually develop a new mental health research centre called Alive. It will be based at Melbourne University. It will be an academy of lived experience and co-design living labs, working with 14 universities and research teams across all jurisdictions and states. And it will be working around mental health and suicide prevention reform with lived experience at the very heart, participating as co-designers in research. And that's building on pioneers of lived experience that have started from many years ago, the Kath Ropers of this world, Helen Christensen, Professor Kathy Griffiths, who started the Centre for Mental Health Research in Canberra. They were those the pioneers of the arena of lived experience and research, and we have to continue this. And to see this announced is very much in line with Vision 2030 and all the other reports to say we've got to be in the driver's seat with everybody else.
So that sort of gives you, that must give you some comfort that these are not just reports, that you're actually seeing action already from them.
Absolute comfort. It's an emotional roller coaster. It's oh my gosh, I wished we'd had this years ago, decades ago. It's a sense of relief. It's still a sense of grief, but it's also that sense of, hey, hang on, we are moving in the right direction. Slowly, slowly, gently, gently, maybe not as fast as we might like. And as Stephen said earlier this morning, unfortunately, we're still not going to be able to prevent some tragedies as we go on this journey, but we're trying. And there are many people, not only the lived experience sector, but all of us who are around this table in various forms, giving ourselves, giving our hearts and souls to try to make a difference.
Thanks, Ingrid. And I'll move on to Daniel, and I'll ask you the same question about how these reports, whether they align with the vision that you have for a mental health system. And there's also an audience question I'll bring in as well for you. How can we ensure that Indigenous people are better involved in mental health reform and the decisions made about the design of services? I think the echo might be coming from your end, Daniel. I don't know if it's up a little bit loud or, but let's push on, but see how we go.
Yeah. Okay. Sorry about that, Sophie. Yeah. Thanks for that. And yeah, it is very much well overdue. All this stuff to do with mental health. I recently spoke at the Royal Commission on behalf of my own personal lived experience, but also working in the Aboriginal community itself. And I think a way is to get Aboriginal services, Aboriginal organisations, Aboriginal people involved with building these programs and coming up with these ideas rather than being a government-run thing or something like that. That's my opinion with that sort of stuff. Just to get more Aboriginal services, different Aboriginal ACCOs involved with the decision-making process with it all.
Do you think
Yes.
there's enough? There's been enough focus in the suicide prevention advice and also the Vision 2030 of the Indigenous perspective?
Yeah, I think there has. I think there has been. I think especially with this Royal Commission, it's really brought out a lot of holes in the mental health sector in general. But you know, a lot of Aboriginal people have gone through some pretty traumatic things involving the mental health system in Victoria. So in order to make some changes, yes, I think it's a way that we need to move forward. And I really have hope that there's going to be more services and more programs available for Aboriginal people in Victoria moving forward because of this Royal Commission. So I think it's a really good thing for the Aboriginal community in Victoria. And there's other things that I'd like some things implemented within the Aboriginal community that will benefit Aboriginal people trying to seek help and support for their mental health issues. So did you want us to run over some of them, Sophie?
Yeah, I might. And I've just been advised that it might be the volume on your speakers that might be a little bit loud. That might be why we're getting a bit of an echo.
Okay, sorry. How is it now? Still?
It sounds a little bit better, but apparently it's the volume on the speakers. But yeah, if you wanted to take us through one or two, what are the specific things that you would like to see?
Okay, so in my opinion, I would like to see more healing centres on country, regional Victoria, not so much in the city area, a place where people can go to seek help if they're struggling. At the moment, we've got some services in Victoria, Aboriginal services, drugs and alcohol with youth and adult, not by no means enough, but unfortunately people sort of need to have drug and alcohol issues to get into these type of services, or they need to be on a corrections order, they need to have something going on. And I think it's a big lack for someone who might not be having substance abuse issues, but they're struggling with mental health issues, you know, and they really need help, but they can't seem to get into these services. I think we really need healing centres out in regional Victoria where people can go and stay for however long, whether it's be weeks, months, however long it is, but just to get that time away from their own community, from their own lives, and try to learn some things that they've never learned before about mental health, talking therapy, seeking professional help for the first time. And I really think that's a really big step for us as an Aboriginal community to move forward and get the right support in place. And I really feel as though they need follow-up support workers. So say someone lives in, I'm just going to use, say, like the northern suburbs or something of Victoria, and they go to one of these centres that's in regional Victoria. They might spend 3 months there. Things are going really well because they have day programs. They have their family come and visit them, and they're going really well. They've sought all this support. I really feel that when they go back home, that's where a lot of the challenges can start to happen, when they get involved with their community and they see their friends and stuff again. And it's a whole other thing of challenges.
So you need that follow-up care.
Follow-up support is pivotal. So whether they have a support worker for an extended period of time, like whether it be 12 months or whatever, a long period of time where they can check in on them. And it doesn't even have to be it doesn't have to be at a super professional level. It can just be someone to catch up with them and take them, that just do something like almost like that, take them out into the community, go for a walk in the park, just basically checking in on them, to making sure that they're okay, and making sure that they're following up with their appointments and any other help that they might need. I think that's super important. And to implement healthy lifestyle at these healing centres and with these workers as well, I really believe that getting outside active is a really important factor in working on your own mental health and diet and everything like that. And it's a whole range of things I really think is super important. And also prevention programs, people talking, whether it start off with our young mob in community, talking about mental health, making sure that it's something that these young kids can feel comfortable bringing up with their parents, saying, listen, you know, I'm getting bullied at school, or I'm struggling here, or, you know, something's going on. And whether they can go to a co-op or they can go to a local service and get help at that young age. And if we can break that stigma early on, then it means that in the future they're going to feel more comfortable talking about mental health, and it's not something that there's got to be shame about with themselves. So I really feel that's some important things that if we can get this out of, as the Aboriginal community, if we can get this sort of things out of the Royal Commission and we can get the funding for it, I think it's going to have an amazing effect for our community.
Oh, look, thanks, Daniel. Thanks for sharing all that. That was fantastic. I'm keen to ask the panel, you know, we've had a number of different reports. We've got the Royal Commission, we've talked about the Productivity Commission, and then the Christine Morgan's reports. And I'm just interested to ask all of you how well you think that those different reports fit together in terms of the vision for the mental health system of the future. Maybe I'll start with Jayashri, to start with you, Professor Kulkarni, whether you think there are enough similarities in terms of their approach that we can have a united system by sort of, you know, picking the best of the reports and making sure that they're not conflicting in their approaches, or are there enough points of similarities?
I think that the similarities certainly outweigh the differences, and I go back to Ingrid and Daniel's comments that in fact the consumer perspective is central in all of the reports. So that's a big difference to lots of things at the moment, but it's also a very clear message about the driving force in the next round of actual change. Again, I think that the things that we've been discussing in various forums and groups is about the specific, how is this all going to work? Now, maybe I'm just impatient because I've been in the system, working in the system for a very long time, and you know, sort of seeing things and drumming the drums about various things that are just not good. And I guess it's about, okay, how are we going to make this work? And that's why I said, you know, I've read the Royal Commission report on several occasions and now, and I just haven't got a picture of what is going to happen and how it will look. And, you know, again, we need to make sure that the new system, whatever that is properly resourced, and that we don't kind of have a situation where it becomes total chaos in trying to get to a good system, but then in the meantime you get a lot of lost people, and that really bothers me. One other thing that I wanted to talk about, the suicidality aspect of things. There is a group that don't often get mentioned, and that is middle-aged women. So middle-aged women, if you look at the Bureau of Statistics data and you look at many other databases, middle-aged women between 45 and 54 in Australia have a very high rate of suicide. They're the second highest rate of completed suicide. The highest is in elderly men over 80, 82. So, you know, we tend to think about suicidality as particularly an issue in youth, and it's an issue in everyone, no doubt. It is a complete tragedy in anyone, but we must not forget that there are specific issues that people at different times of life, and people, like women versus women compared to men, are facing different issues.
And with that cohort that you mentioned, what do you think needs to happen to help address that cohort so that they get the support they need?
So one of the first things is to actually recognise that there are differences for men and women experiencing mental ill health, and then there are different issues that face, for example, Indigenous women, and again, you know, women of a non-English speaking background and so on. So there are differences. So at least if we start to talk about the differences and the groups that are there, it's not all about youth. I want to make that point clear. Yes, we worry about youth. We want to do the best we can, but there are other people in the community who are experiencing a lot of anguish, a lot of stress in terms of mental health, and COVID took the cracks and made it into big chasms. And I've got to say, post-COVID, women are really struggling with their mental health, and women struggled most during COVID, and the surveys have been done that give us the database to say we've got to help to fix up this, because we saw terrible depression and anxiety in women who were trying to do homeschooling while they were worrying and looking after elderly relatives, while they were also trying to hold down jobs, and often lost jobs because they were in the casual workforce. And then we had a lot of women in the health workforce who were exposed to virus and other illnesses. So, you know, that's just a tip of the iceberg. But I think we need to have a system that really recognises the special and individual needs. The closer we can get to tailoring a package of service for individuals, the better we're going to be, because you and me and Ingrid and Daniel are all different. And so, you know, we need to recognise that.
And so that someone, if they are struggling, they can look at what's available and think, well, that there's something there to help my needs. And so Ingrid, I might move on to you just with the different reports and how they all fit together, and whether you think you know, there's a sort of how they're going to work together in practice, I guess, you know, given they are several different reports, you know, different authors. And do you think there's enough similarities that they can come together with a shared vision of how the future will look like and what it'll look like in practice?
Yes and no. First of all, I'd actually like to make a bit of a distinguishing note around mental health and suicide. They're not always mutually exclusive. And so suicide behaviours can be it's multi-complex, it's multifactorial, as is mental health. We are human beings, so we come with a whole range of a big package. There are social determinants of health that impact both our mental health and potentially suicide risk. So I just want to make that clear, that mental health isn't always going to end in suicide, and nor is suicide always because of a mental health issue. So, but building on that, I have to say I feel so proud and privileged to have been on the task force and involved in the Compassion First report. Having participated in that report and working with a range of lived experience voices who are very courageous in sharing what for so long has been a taboo. Talking about suicidal ideation, talking about suicide attempts is still really painful, uncomfortable, shameful. I know how I feel when I'm standing here or sitting here saying that I'm a suicidal ideator and I've tried to take my life. I feel ashamed. I feel agony and pain in saying it, because I know I don't look unwell, or I don't look the certain stereotype perhaps that people may be having in their minds, or perceiving people to have this appearance of distress. And that's the key, is that so many of us are really great at putting a mask on and not sharing, because we've learnt to play the game of a chameleon, to put the mask on our faces so that we appear high functioning and that we can do anything. This Compassion First report highlighted 2,000 people's stories around different touch points in their journeys of what they wanted before they got to that crisis point. As they were getting to those situations, what we were wanting was to be acknowledged, to be validated, to have this pain recognised as if you had a heart attack. If someone's unconscious, we're uncomfortable. If someone does have a heart attack in front of us, that's scary. Suicidality is scary. So let's accept that from the front end. And let's acknowledge that this is about personal pain. It's contextual. It's about pain that we don't know what to do with and we want to get rid of it. It's not necessarily about wanting to die. And what came out of the Compassion First report, there were common themes, and those common themes were feelings of hopelessness, worthlessness, feeling insignificant, not feeling valued, not feeling cared for, feeling disconnected from self. And so why the report was called Compassion First is because that's what everyone actually wants.
Yeah, so that's the the thing that draws all everyone's stories, despite how different they are, that at the centre of it, that's what people need, is that compassion.
And that came out through the COVID, and it's come out through humanity. How do we connect is through relationships. How do we start relationships is through kindness, through engagement, through developing human bonds. And so Compassion First is and was the starting point, and I feel a seminal piece of work in which Suicide Prevention Australia, and I do have a conflict of interest as I'm a part-time employee with them as well, but we're building on that work, and this is where the Lived Experience Co-Design Centre will be pivotal in actually doing more research in these areas around lived experience ideation and attempts, so that we can learn what's needed before tragedy strikes.
And that was also very, thank you for sharing your story, Ingrid. You know how valuable it is to have someone like you know, with your lived experience on the panel when we're talking about these issues, because it really is at the centre of everything that these reports are all about. And so we really value your time here with us today and sharing your experience. And it was also good to hear from Christine Morgan as well, that the door is still open for people who want to share their stories. It's not like that window has closed. So that's something for the audience as well, that there's still that opportunity, which is great to hear. And I really think the work that Christine's done, starting off with in eating disorders and now, you know, more broadly in mental health and suicide prevention, has just really lifted the value of lived experience as well, and put it on a stage. It's a national stage. It's been really, really good. So I might just quickly, we're running out of time, so but I'll quickly, before we move, I'll move to just Daniel, just to get your point of view about before we go to a break, just the different reports, and whether you think that there is a vision that you can see coming through the, you know, with the Vision 2030 and the suicide prevention advice, along with the Royal Commission and the Productivity Commission, of a system that's aligned and that sort of fits with something that you would like to see, particularly from the
thanks, Sophie. One thing I'd like to see is for people for all spectrum of the mental health to be able to seek help, you know, so it's not people that, it's not always a last resort, people that are on a lot of medication, they might be in a hospital or something like that, they might have attempted suicide, you know, that's very important that these people get the help they deserve. But I also feel it should be for people as well that might just have very minor symptoms of mental health issues, and they might just want to get they might want to get help for it. I really feel as though it's important for those people to be able to seek help as well, without having to be at a certain level of mental health before you can actually seek services. You know, within the Aboriginal community, there's actually workers that have taken their own life. You know, that's not uncommon at all in our community, because we've got a lot of stuff to deal with. We've got other people's traumas we're working through. We're working with our own community, sometimes even our own family and friends. So it's very important that someone like that might be working and might be on the outside, be switched on and have their stuff going on. But I really feel it's important that those people can seek help as well, as much as anyone on the spectrum. And also as she was saying before about young people and stuff, I really feel as though it's just all different groups. So if we can really put some support towards young people, if we can give some support to to women, we can create mothers groups, we can give support to men and have men's groups and dads groups and things like that. I think it's a win-win for the community, because if we can let these people, say as those middle-aged women or men, seek help, then it's only going to have a ripple effect to our young community anyway. That, you know, if they can sort out their mental health and seek help, then it's a big plus in the community. So I feel as though, all groups should be included in this, all from all backgrounds and everything, from all ages and all diversity. That's super important, that these people can be able to seek help as well, and that there's funding is split up towards different groups and ages, rather than a whole chunk being thrown towards a certain sector. I think that's very important as well. So, but all in all, as I said, I'm very confident that things will turn itself around. If the money's there, the funding's there to get put into these programs and get put into these services and these workers, I really hope that it can happen ASAP. Obviously, you know, during COVID, a lot of people have struggled, but even stuff like community barbecues, community outings. I mean, I know a lot of community members come up to me once the restrictions eased, and they were saying they really struggled because they weren't able to go to these barbecues. I work in the St Kilda area as well, and we have the Monday weekly barbecue and Thursday every second week and things like that. And a lot of people, they might not even need to speak to a psychologist or a worker, but they just go to these events, they go to these barbecues, they say hi to people, they speak to some workers, and that's all they need to maintain a good mental health for them. It's that sense of engagement, it's that sense of community, it's that sense of belonging. They have a meal, they have a feed, they have a laugh and everything. So those programs are also very important. I should have touched on them before, but more community programs, as I said, like mum's group, dad's group, where people can talk about, you know, what's going on in their life and things like that. That's also very important, Sophie. So I
agree, and that sense of that shared experience and feeling like you're not alone and that other people are going through the same thing. There's you know, there's no substitute for that, really, just being, you know, with the same room, or even virtually. But if you can be in the same room with someone and realize that someone else is feeling exactly the way you are, and you're not the only person feeling that way, that can make a massive difference. So thank you, Daniel. And look, we've run out of time. We better go have a break. And thank you so much to our panel, Professor Kulkarni, Ingrid and Daniel. It's been amazing, and I really appreciate your time today. We're going to have a break now till for a little while. Don't forget to go to the exhibition hall, and we'll be back here at 12:30. So it's not a huge break, but go to the exhibitor hall, have a look at the sponsors, and thanks for your input so far. And we'll be back here in about 15 minutes or so. We'll see you then. Welcome back, everybody. Hope you enjoyed that little break. It's been a full program, but I thought that last session was fantastic. So hope you enjoyed it. Right, now we're delighted to have some leading child mental health and wellbeing experts to join us. We've already heard today the importance of early intervention, getting in early and identifying problems and preventing people from becoming ill as they get older, and setting children up for a good start is exactly what this next presentation is about. So we're delighted to have Professor Christel Middeldorp, the Conjoint Professor of Child and Youth Psychiatry at Queensland Hospital, and Professor Frank Oberklaid, AM, Director of the Centre for Community Child Health at the Royal Children's Hospital and the Murdoch Children's Research Institute. Now they're going to co-present this session, so we're really looking forward to hearing from them. And as I mentioned, as always, there will be a chance to ask questions, so please be thinking about the questions that you have for them, and there will be a good chance to ask them some questions at the end of the session. So I'll hand over to both of you. Welcome, and we're looking forward to your presentation.
Thanks very much, and thank you very much for the invitation. Let me see if I can just share my screen. Bear with me for 1 second. I'd like to begin by acknowledging the traditional owners of the land, wherever we happen to be listening to this, watching this, and pay my respects to elders past, present, and emerging. In my situation here in Melbourne, it's the Wurundjeri people of the Kulin Nation. Bear with me for 1 second. Can everybody see that now?
Yes, we can, Frank.
Thank you. So Christel and I took on the co-chair of the national strategy at a time when there were lots of reports and reviews and reform, lots of processes going on. So the draft has been released earlier this year with about 170 responses, but this is a pretty complex policy environment. There's lots of reports and recommendations that will be going to government. So I suspect that we'll still have to argue strongly and advocate for child mental health to continue to be on the radar screens of policymakers. This is how the process of the development of the strategy took place. It was under the auspices of the Mental Health Commission, the National Mental Health Commission. Christel and I were co-chairs, and we had some very, very strong supports in helping us put together this strategy. There was a multidisciplinary expert advisory group. There were 2 working groups, one from birth to 5 years of age and the second one 5 to 12. There was an Aboriginal and Torres Strait Islander reference group, a national steering committee that included representatives from every state government. We undertook, despite COVID, quite extensive stakeholder consultation with professional bodies, with colleges and organisations and peaks, and then a second round of consultation, particularly with vulnerable and at-risk groups. This is part of the complexity of child mental health. This is a slide that really is designed to look at the whole picture of mental health, not just the treatment of mental illness, but all the way back to parents and families, and then the primary and universal service system, secondary systems, and the tertiary system. And we really wanted to step back a little bit and look at the whole system rather than any aspect of it, and not just the service system, not just families, but We tried to pay attention to workforce and resourcing, the importance of place, particularly with a focus on rural and regional. And then, as Christel will elaborate later on, the importance of data and research and evaluation. There were 8 principles to design this strategy. These are pretty straightforward: child-centered, strength-based, prevention-focused, etc. All of us advocating for child mental health would regard these almost as motherhood statements, but it was very important to put those out at the beginning. And there were 4 focus areas that we paid attention to: family and community, the service system, education settings, and evidence and evaluation. And I'm going to give you some examples from 1 and 3, and Christel will talk about the service system and 4, evidence and evaluation. And for each of these focus areas, there were 3 subheadings, if you like: key objectives. What did we want to achieve in each of these focus areas? What actions were we recommending that would achieve these objectives? And then finally, indicators of change. And those of you who have looked at indicators in the whole child mental health space or child development know how challenging that is. Yet we really wanted to make a statement that we didn't want a report just to go out there and gather dust on the shelf. We really did want to at least have an attempt at measurement and follow-up, and the indicators are very much in draft form. So you'll see from this circle, it's probably a little hard for you to see, this is the wheel that covers the principles, the actions, and the objectives. So these are the 13 objectives that 3, 6, 9, 14 objectives that cover all of the 4 areas. So this was an attempt at a systematic and a systems approach to reform, again, looking at the whole pictures. And if you recall, under each of these objectives, there's a whole series of actions and a whole series of indicators. And I just want to very briefly summarize a couple of examples. This is the first one under family and community. Objective 1 was supported families. And the 3 subheadings under that were to address risk factors in the perinatal period, address adverse child events. We all know the relationship between adverse child events that happen in those early years and long-term outcomes. And then particularly to identify and support those parents who are struggling. There's a list of actions there: evidence-based parenting programs, embedding social emotional modules in antenatal care and parenting courses, promoting universal supports such as helplines and evidence-informed resources, and then finally place-based approaches, understanding that communities are different, and we can fairly reliably identify those communities that are disadvantaged or are vulnerable, and we should be putting supports in place in those communities before the children turn out to be struggling later on. And then these are the indicators for that particular objective, looking at the degree of parent awareness of and use of evidence-based parenting resources, the use of systematic methods to provide support to children and families who are hard to engage, looking at the level of understanding in families and the community of child mental health and well-being, and their understanding of the options for obtaining support, and the implementation progress of those place-based approaches designed to address those risk factors in vulnerable families. The next focus area are education settings. This is again a summary of the actions. And if you read through these, you'll see that it's a fairly ambitious set of recommendations that we think governments should take, that all early childhood and school settings should have a student wellbeing plan in place, that schools should employ a wellbeing coordinator to establish and maintain relationships, including outside the education setting. Somebody in every early childhood and school setting should be designated to plan and coordinate these activities, provide funding for targeting student needs, etc. I won't read through that in detail. And then again, an attempt at measurement. What are the indicators of change? When will we know that we're making progress in this area? The extent to which children enjoy a sense of engagement and belonging, and the prevalence of bullying and discrimination, implementation progress of planned activities, the strength of relationships between schools and locally available mental health service providers, rates of children's participation in evidence-based programs, and last but not least, very importantly, the level of educators' knowledge and confidence in addressing mental health problems in early childhood settings and in schools. We also looked at stigma. Stigma kept coming up all of the time, both in terms of parents anxious about getting support for their children, even if they knew where to go, because they have to admit their child may have a mental health problem. And most of the consultations that we had with various stakeholders and people with lived experience also mentioned stigma. So one of the strong recommendations is that we review the language of child mental health for two reasons. One is to address stigma, but also to see if we can't get a common language between the various different professional groups who are involved in children's mental health. We know, for example, that the education and health sectors use quite different language to describe children with mental health problems. So we're recommending a continuum. Spectrum isn't quite the right word in there because it does have connotations, that with 4 landing points: healthy, coping, struggling, and unwell. We want all children to be healthy. Inevitably, as children go through life, there'll be little hiccups and transitions, and we hope that they'll cope with those. And the role of parents and carers and teachers is to build resilience and help children cope with the everyday stresses of life. We also know that some children are going to start to struggle for one reason or another. And what we want parents to do and professionals to do is to pick up those kids that are struggling as soon as we see evidence of that, and build scaffolding around them to try and get them back to coping. And of course, there are those children that will be unwell. So we're not suggesting for one moment we stop making diagnoses. Many of these children will need a diagnosis, but we don't want a diagnosis to determine whether or not children should get services. And we certainly don't want diagnoses to get in the way of parents wanting help. So we really wanted to try and develop a strategy that led to a fundamental cultural shift in the way that we think about child mental health and well-being. We wanted a change in language that refers to a well-being continuum. We wanted a change of status to give child mental health parity with physical health, and we've heard this call in adolescent health and adult health as well. We wanted a change to ensure access and equity in all systems, and we heard again and again that children and families have major problems of access and equity to services. We want to change towards needs-based access to services. And importantly, we wanted a change in the collective understanding of how important the role of families and communities and services and educators are. Just some acknowledgements. It was wonderful to work within the auspices of the Mental Health Commission. So ultimately, we reported to the board. Christel and I want to acknowledge the staff, especially Sarah McNeil and Alex Haynes, who ended up writing a lot of this, and were just a fantastic support. Our expert advisory group, the working groups, and the Aboriginal and Torres Strait Islander reference group, the National Steering Committee, and the very diverse group of stakeholders that gave of their time to consult, and also the 170 individuals and bodies that have made formal responses to the draft strategy, which are now being collated with a view to the final strategy being released in the next couple of months. So I think I'll stop there, if I may, and hand over to Christel.
Thank you, Frank. Can you unshare your screen so that I can?
You should be ready to go, Christel.
Yeah.
Great.
Can you see it now?
Yeah, we're seeing your screen now. Thanks, Christel. We're seeing yours.
Excellent. So I'm just going to, oh, okay, it's fine. So this is the wheel that Frank already showed, and I'm going to talk about this part first and then about the evidence and evaluation. And a lot of the issues that we are trying to address in the strategy have already been mentioned by Professor Stephen King and by Christine Morgan. So about the lack of access to care, especially for people with the milder symptoms, which was referred to as the missing middle. But there's also a lack of access in the rural and remote regions. And then there is perhaps not so much lack of access, but difficulty with navigating the system, as was pointed out by Christine Morgan, because the system is so fragmented. So, and because comorbidity is almost the rule, especially when you go to the children that are really unwell, those children also fall between the cracks because one service tells them that they are too anxious for their neurodevelopmental focus, and the child and youth mental health service, for example, may tell them that they have too many neurodevelopmental issues. So the fragmentation of the system and the fact that a lot of services for milder symptoms are accompanied with out-of-pocket cost make it difficult for people to navigate the system and also to access the system. And one of the priority actions that are mentioned in the draft to solve this is to trial sites, both in urban and in rural areas, of a service model where child and family care are integrated and providing a holistic assessment and treatment for children between 0 and 12 years old and their families. And I'll go into that model in a bit more detail, what it would look like. So it would mirror the holistic approach taken by the ACTROS services. So first of all, there would be a multidisciplinary team, including a pediatrician, a child psychiatrist, occupational therapist, speech pathology, and psychology. So a broad range of specialties that can all contribute to a good assessment of children and a good treatment. It could be face-to-face, but also online to serve the people in rural and remote areas. We acknowledge that there are some families that have difficulty also accessing online services because they have bad internet connections, or because the house is crowded and there is not really a quiet place to attend a session. But at least it will serve some of the rural and remote families. And addressing the missing middle, it will be a low threshold service. We think it should be based on referrals by GPs, but further, there is no threshold for the severity of the symptoms. And it would also include a parental assessment where parents are asked whether they experience mental health issues themselves. And then there is treatment for the milder issues. There are parenting programs offered. There are, for parents who are suffering, they can, for example, have an enhanced parenting program. But of course, if the symptoms are severe, they would be referred further on. But apart from these treatments addressing mild symptoms, there will also be more specialized treatments, but those will probably not be offered at all of the services, but services may have their specialization. So there may be services that specialize in care for children that are traumatized. There may be centers where they specialize in treatment for children with autism spectrum disorder or milder social skills issues, and they may offer groups for those children. So it would mean that for more specialized services, people would need to travel a bit further from their homes. But the idea would be that the referrals between the centers would go very smooth and that they would really collaborate. But we don't think it's feasible to offer these specialized services at all these centers, because there are just fewer children who need those services, luckily. So regarding the implementation, our view is that it shouldn't be added to the current services, because there are already services enough, but would emerge out of these services, apart from in the rural and remote areas where there may really be a lack of service, and this can come as a service and not coming in place of other things. Then about the evidence and evaluation. So it was already mentioned today that we lack good data and we lack good evaluation. So these are the actions. So first of all, it starts with providing services and programs that have proven to be effective through robust evaluation, and then ensuring that these services are implemented with high fidelity. So completely, and also in the way that they are meant to be implemented. And then there needs to be an ongoing feedback loop. So even those programs that already have been robustly evaluated, they need continuous evaluation. And for example, people can look at whether there are certain groups that respond not as good as other groups, and then see whether the program needs to be adjusted for those groups who don't respond well. As we know, there up till now, we haven't managed to find treatment for all children. There are always children who don't respond to certain treatments. So, and in that way, by that service evaluation, we can inform how to improve those treatments. And then, of course, if you have made an adjustment, then you need to evaluate that adjustment and see whether that provides a better outcome than the previous program. And as was emphasized already a couple of times today, and I would like to echo that, it's very important that these feedback loops also involve the children and the family. So it's not only based on how the clinicians evaluate the program. So that would mean that you embed evaluation from the start, then you improve your treatment based on the evaluation, and then you evaluate the improved treatment. And you can, of course, also do a randomized controlled trial. But the main message that we would like to bring across is that research should be well embedded in all services and should be part of our clinical culture. This is an example of a project that we've been doing here in Brisbane, and that's submitted for publication. So this is based on the routine outcome measures that are completed by children or by clinicians for children that are attending the child and youth mental health services, the community services. And as you can see here, is that according to the clinicians, the children improve quite well over time. That's also confirmed by the scores on the CGAS, and it's also confirmed by parental SDQ scores. So everybody is in agreement that at the end of treatment, children have fewer symptoms than they had at the start of treatment. and that's with an effect size of about 0.9 standard deviation, which is a very substantial and clinically relevant effect size. Still, these scores on average are in the clinical or in the subclinical range, meaning that these children at the start of treatment score very high, and then they improve quite well, but even at the end of the treatment, their scores are still in the subclinical or clinical range. And I think this simple example of just looking at routine outcome measures shows what a wealth of information these measures have, because what we see is that KIMS is doing an excellent job, but that the children still need care after discharge, and that we should look at why are children discharged. Is that because there are so many children knocking on the door and very acute, and that's the reason why they are discharged? Or are they so severe that it's difficult to achieve full remission? Those are the things that we need to follow up on and see how can we serve these children even better. Or another possibility is that these children are referred on to other services and that they in the end achieve full remission. But at the moment, based on these data, we can't say. It's just an example of how you can extract information and then get other questions and follow up on this if you have the right data. So I must admit that my thank you slide doesn't cover as many people as Frank's did. So I'll quickly get rid of it. And I would like to echo everybody that Frank has acknowledged and apologize for the people that I've forgotten on this slide. Thank you for your attention.
Thank you, Christel. And we're going to bring Frank back on as well. I might bring Frank, there he is. So I'm just going to ask you a couple of questions and then we're going to go to audience questions. Thank you very much for that presentation. That was fascinating. I just wanted to ask you, what has been the reaction to the strategy so far? Maybe Christel and then Frank. What's been the response?
It's difficult to summarize 170 replies, and I must admit I haven't read them all. But I think in general, people were positive about it. And of course, there are also always recommendations from to provide more attention to certain groups, and which we will definitely take into account and see whether we can extend some of the sections. Frank, what would you like to add?
Yeah, I think it was generally positive. You know, we sometimes use the language that child mental health has been the elephant in the room for so long because it's been fighting for policy attention with adult and adolescent mental health services. And certainly all the stakeholder groups we spoke to were very positive about finally child mental health having a space to discuss the issues and the recommendations and how we could reform it. And we're also encouraged by the fact that there are 170 formal submissions to the draft. So I think it was positive. I think there was lots of people welcome that child mental health is on radar screens, and certainly I'm biased and Christel is biased because we work in this area. But I think the challenge now is to keep on advocating to make sure that it doesn't fall off radar screens unwittingly in this complex policy environment we find ourselves in.
I was very interested, Christel, in the system you were talking about of the integrated care sites for the 0 to 2-year-olds and how that would work with the multidisciplinary teams. How likely is it, do you think, that that sort of system would be introduced, and would that be on a state or a federal system, do you think?
So I'm quite confident that it will be trialed, and the reason is that I looked at the Royal Commission and they also recommend something similar, and it's so everybody is so aware of the fact that the system is so difficult to navigate and the lack of care for children with milder symptoms, and also the lack of care for the very difficult symptoms. So I'm pretty certain regarding the funding and whether it should be federal or state-based. I leave that up to the politicians to decide. I think in the end, as was also much emphasized in the report for the Royal Commission, is that it should be a joint project. I mean, both the federal government as well as the state governments would benefit from a good mental health care system.
And it was interesting when you were saying that it would be a low threshold as well. I thought that was really interesting. So you'd be capturing a bigger cohort of people who might need access to that really valuable multidisciplinary type of care. A question we had was, how did the strategy incorporate the lived experiences of young voices and their carers when you were developing the strategy?
In the second round of consultation, we had focus groups, Zoom focus groups because of COVID, with quite a few young people, and they shared their experience of being a child before they got into adolescence and growing up. We had a consumer rep on our expert advisory group, and I think the voice of the carer, the parents, the consumer was pretty loud all through the consultations and all through our deliberations.
Oh, that's great. We just had a comment from Lindy, just following up from Christel, what your pilot you were talking about. She's saying, we're piloting an exciting early intervention, truly multidisciplinary program in Geelong, servicing one of our most disadvantaged groups of children 0 to 6 and their families, and it's going exceptionally well. So that's good to hear. One question I thought was interesting was someone's asked, in my experience, when a child is struggling, it's often the parents are struggling as well. And how can this strategy help parents, particularly if they're not necessarily forthcoming in wanting that help? So how do you build that into services or help take that into account that that the parents are the ones that might need the help as much as the child?
So that's really a question that's a part of my research as well. So we know that about 40% of parents also have mental health issues. This is data from specialized child and youth mental health services. I think the first step is that we have more focus on those mental health issues. I mean, all clinicians know that parents have issues, but because the way child and youth mental health services are separate from adult mental health services are difficult to access. Clinicians often have nowhere to go, and may therefore also not ask very in much detail. But I think the first thing to do is to ask parents, just as part of your of the first assessment, how they are coping, and not because it's their fault that their child has issues, but we just know that families are struggling, and mental disorders run in the family also because of genetics, because they may all suffer from the same stressors. So that should also be clear to parents, that we are not asking them because it's their fault, but just because we know that some families need more care, and especially families where both a parent and a child suffer, they need more care. And then we need to provide those parents also with low thresholds ways to treat them. So that can be part of those services, those centers, that if it's not too severe, that there are short programs where parents can go, for example, implemented in parenting programs, or they are referred onward.
And what difference do you think it will make if some of what difference will it make to Australian children if some of the key planks of your strategy are incorporated? What difference do you think it would make sort of going forward to their health and well-being?
Well, we want all children to thrive and be happy and not have these sorts of issues. I think that this is really a medium to long-term view of Australian society, because we know that more than half of adult mental health problems begin in those early years. And even broadening it beyond mental health, we know that the early years of a child's life are so critical in determining the whole life course. So if we can recognise that the child, investing in children is central to investing in the future of Australian society. We'd like to see children grow up, be happy, be content. When they're struggling, for those issues to be picked up early and scaffolding be put around them to support them, so they don't end up at 14 or 15 or 18 with a lifetime of struggle that was unrecognised or unaddressed.
So it's sort of taking the messages that we've been hearing about intervening with, you know, with teenagers and but even further, even earlier in the process, to sort of not wait till it gets to that point until you're offering people help and support.
Yep.
We've got a couple of questions here about, it says the strategy does a good job of recognising the needs of children from diverse communities like Aboriginal and CALD communities. Were there any specific measures to support LGBTIQ children in the strategy, and what needs to be done to make sure that there's that cohort is looked after as well?
I don't think our consultation didn't extend to an LGBTI group. I think that we would hope that as those kids start to struggle with identity, people will notice they're struggling and put in place appropriate interventions, irrespective of the cause of their struggle. So we hope that our strategy is encompassing enough to pick up those children early on as well.
And we've got a couple of other questions here. How do we make sure that the influence of social determinants of health and factors like family poverty and family violence are addressed so that they align with children's mental health reform, so that we look at it in totality?
Well, the research is so clear about those influences increasing the risk of children. We're focused on child mental health and highlighted the importance of those social determinants, but Christel and I can't try and make recommendations to fix up all those issues of society. But I think we do need to recognise there's an economic as well as a human cost to all of these things, that making sure that adults who are parents are fulfilled and have steady jobs and good housing and are not stressed in the workplace, that's just as important to the future of children than anything else that we've recommended. So it's time for this sort of to have a broad lens on children, on their outcomes, on what affects them, and recognise that there are a whole lot of things outside the child and outside the family that really have a big direct and indirect impact on family stresses and therefore on children's mental health.
So you put the strategy out now. What's the time frame in terms of the next steps now that it's been put out?
Well, the people in the Mental Health Commission are busy collating those 170 responses and trying to make head or tail of them. And once they've summarised that in some way, then we'll all get together again and look at amending the draft. And we're probably aiming to get the final strategy out within the next 2 or 3 months, Christel. I think that's probably our timeline, is it not?
Yeah, but it all depends on how quick we can go through the responses, because of course we want to implement the responses as good as possible.
And then once you've got the final report, do you then deliver that to the federal government and for them to respond to it?
Yeah, the Mental Health Commission then delivers it to the Minister for Health, Minister Hunt, and then they respond in an appropriate way. Hopefully, not just with funding, but Christel and I were pretty clear that this is not just about more money. Yes, we do need more resources, but if the response is only money, then we won't have succeeded. That what we're really asking for is a fundamental shift in our thinking about child mental health, significant reform of the existing service system and the existing way we look at children. And then state-federal relationships, you asked about that earlier on. That's such a critical part of it. We need an integrated policy approach as well as an integrated service approach.
And there's another question here. What role is there for education to play in achieving parity for physical and mental health literacy? Because you said earlier on that you want to elevate children's mental health along with children's physical health. So what role does education play in achieving that?
Well, I think all 3 reports, the Productivity Commission, the Royal Commission, and our strategy have identified schools as being an ideal platform to build resilience, to build wellness programs, importantly, to detect children that are struggling very early. We have trained professionals spending 5 or 6 hours a day, 5 days a week, 40 weeks a year, observing children in various contexts. So it's really important. And some of the research that we've done suggests that teachers now see mental health as core to their work, core to their professional practice. But in the next breath, they say they don't have the time and the school doesn't have the resources. So schools have a critical place to play. And I think that's been identified, as I mentioned, in all 3 reports.
And I guess this is one question that we've put to a few of the speakers we've had today. What would success look like for you now that this report or the draft is out and you'll incorporate the comments and other things, but when it actually comes to being implemented, what would it look like to you to say that it's not just a report that is on a shelf, but it's actually something that is put into practice? What are the sort of the practical applications that you want to see to say that, yes, that this report is making a difference?
Christel?
I think especially the improvement in access and less difficulty navigating the system, that would be an outcome that would show success. And then you also, yes, I think you also had some other measures like reduce bullying and things like that. And Frank, were there other things that you would like sort of that are in your front of mind that you would see as success, the sign of success?
Well, I would agree with Christel, but I think I'd like state and federal governments to agree that they have to be on the same page, that this is not going to be a 12-month plan, it's going to be a 5 or 10-year plan. And I would love state and federal governments in a bipartisan way, sorry, a non-partisan way to get on the same page, agree that it's going to be 5 or 10 years, and then project funding requirements and reform requirements and set targets, 12 months, 2 years, 3 years, 4 years, and stick to those targets irrespective of which government is in power in Canberra or in the States.
And why is it so important, do you think, to set those targets? Is it so that there's some accountability going forward?
Yeah, I mean, the implementation is not, we hope it'll go smoothly, but there's a lot of learning that takes place. We hope this is a reform agenda that's aspirational, that's bold, and we're not going to get it right the first time. So the sort of feedback loops that Christel talked about with services, we need with policy and implementation as well. So at the end of 1 year or 2 years, we need to sit back and say, what went really well? What do we need to fine tune? And just make sure those feedback loops are there all of the time. But yeah, I think we do need to hold governments accountable. It's one thing to promise to recommend everything, but you know, the years go by, and what if we don't reach those goals? So I think it's a mixture of learning as we go and tweaking implementation, because we're not going to get it perfect the first time, and holding governments accountable, making sure that what they agreed to, they actually deliver.
Yeah, and we need to keep momentum. I mean, all these reports coming at the same time show that everybody feels the urge that things need to change. And we need to keep that momentum. And that's also a reason why it's important to every year look how far have we got, and what are our next steps.
Yeah, so it's not just like a sort of set and forget, but you actually implement something, look at the outcomes, see what needs to be tweaked, and then it does keep the momentum for change going. And there certainly does seem to be that momentum with all these reports and all the engagement. But look, thank you both very much for your time today. It's been absolutely fascinating, and congratulations on the strategy. And we look forward to seeing the final report and hoping that as many of these amazing initiatives and this real change is implemented, because it'll make a huge difference to Australian children, and that's something that everybody wants. So congratulations, and thank you both for your time today. We're going to have a panel discussion now, unpacking it a little bit more, but we really appreciate you both spending the time with us today. So thank you, Frank, and thank you, Christel.
Thank you very much, I think.
Yeah, some really fascinating. I really, if you haven't read that strategy, It was put out in December last year, I think it went. So if you haven't read it, I really encourage you to read it. It's got some amazing initiatives in it. So we're going to move to our panel discussion now of this the National Children's Mental Health and Wellbeing Strategy. And I'll just introduce our panel. Adjunct Professor Muriel Bamblett, AO, who's the CEO of the Victorian Aboriginal Childcare Agency. Julie Bornkinkoff, who's the CEO of PANDA, the Perinatal Anxiety and Depression Australia. Professor Harriet Hiscox, the Director of the Royal Children's Hospital Health Services Research Unit, and Imbi Pyman, Carer and Lived Experience Advisor for Mental Health Victoria. So welcome everybody. I think you're all online there now. Thank you very much. So we might go through, there's a lot in the strategy and it covers lots of different areas, and just reminding the audience, we do want your questions again. So, you know, please ask your questions. I'm getting them through here on my laptop so I can try to get to as many of them as I can. But we'll start off, let's start off with asking about the strategy and how it addresses the concerns of mental health and children. Let's start with Harriet. Your view. How well does this strategy address the issues as you see them when it comes to mental health and the well-being of our Australian children?
Thanks, Sophie. I think, like Frank was saying, it's really important we go early in life, and there's that often quote of 50% of mental health problems begin before the age of 14, but children don't wake up the age of 13 and a half with anxiety or depression. We see these things way back, and often, I'm sure Julie will talk about it, in the perinatal period, or certainly we see preschoolers, primary school age children. So I really welcome that focus on much earlier in life and early in the course of whatever the condition might be. And also the integrated care. And I note the Barwon colleagues with their hub, which is up and running, which is fantastic. And we're running our hub in childhood and family adversity in Wyndham in Victoria and Marrickville in New South Wales. And we're integrating health and social care, because I think unless we really address those social determinants of health, we're still going to leave a lot of families behind. So look, I think it's exciting early in life and the integrated care approach, but we need governments across federal and state to come together and think about funding those models of care, because the current Medicare funding model is not fit for purpose.
Well, that's what I was asking about, the funding, because and who's going to pay for it. So there obviously needs to be some discussion of that as well. Muriel, from your point of view, what is the strategy? Does it go far enough when it comes to addressing issues for Indigenous children and families?
Yeah, I think we do need to do a lot more work. I mean, obviously, I love the framework and I love where it's focused, and I think that it does focus on the key areas. But I think I think it really does need to think about how do we actually, because I don't think Australia understands very much around Aboriginal therapeutic frameworks and practice and what that is and how to engage, and how culture is a key component, but how, and I think, you know, Frank talking about, you know, specialised programs, complex. We know that I work in out-of-home care, and we know the complexity of the children that we're dealing with. And I think we know that Western theorists often write about the development, but it's predicated on successful achievement of various stages. But if you're raised not with your Aboriginal family, if you've had disconnect, you know you're Aboriginal, and you can't see your culture reflected in your everyday life, then you become this raging adolescent. And I think that we don't know enough about the impact of culture and the importance of culture. And we don't use culture in our treatment. We don't actually use culture to be able to treat children. So I think there are many aspects of this plan that can, I believe, be further enhanced. But I think we still do a lot more work.
Okay. So, and we'll go through, Imbi, what about for parents and carers? What does the strategy, how well does it address the concerns of the groups that you represent?
Hi Sophie, thanks for having me and everyone, particularly Mental Health Victoria. I love being part of their league, and it's wonderful to be able to have a voice as a carer and a mum. I think the strategy is, I read it with relief and with gratitude, and I agree with the early intervention. I think that's really important. The points I'd like to highlight is that for some families, which was my family, we got catapulted with a trauma into the mental health system. And whilst I understand that it's not just throwing money at the system, of course it's not, and those early interventions are really important, there's so much money that needs to be thrown into a system that has failed so many of us in terms of not being able to access the services, that they are too busy, too full. And it's, to me, it's all about finding the right care, the targeted care, and the very best doctors and clinicians to help you, be it a psychologist, a psychiatrist, and then all the roadblocks that have come within that. So I do think that it has got enormous good intent. And I think from an education point of view, we were very lucky that at our school we had a wonderful support system there, but many schools don't. And I simply also saw teachers being overwhelmed with what they were trying to do, as well as being given extra to do. So I have a concern about that.
Maybe that's one reason why the strategy recommends there being like a wellbeing coordinator or someone specially in every primary school who's specifically there just to focus on that, and also upskilling teachers to, but also making sure that there's someone there whose sole purpose is just dealing with the well-being of the students.
I think so. And Sophie, I wanted to say that it's so dreadful when you have a child or someone that you are caring for with a severe mental illness or in a situation where you need to access those services. And what I believe needs to be highlighted and addressed is the collateral damage of the entire family. So we've got 3 adults now, but so watching everyone, so you start with one patient and then you have an entire family that it has got trauma and that needs assistance and that needs care. And I love the old model that got scrapped years and years ago, where there were respite centres and there were care facilities for a family to go in with a continuing level of care, step down, step up, but with the whole family at the centre of the process. And I think that's what's needed.
True. Oh, look, thank you for sharing that. And Julie, from your point of view, from looking at the sort of new parents and perinatal period, did the strategy hit the right mark for you, or were there things that you thought were great and things that you would have liked to have seen?
Look, Sophie, I think from our perspective at Panda, we were just so thankful to see the perinatal period so heavily recognised as one in which we can actually wrap around families and individuals, and that we can provide better support and be seen as a point in time across the continuum of somebody's life to be able to intervene. I think ultimately the perinatal period is one that we can influence so many parts of an individual's life and the people that care for them. But any point in somebody's life cycle that we can step in and support them is just so fundamentally important. I think, sorry, Imbi, I dropped out my internet when you were talking just then, which I missed. But I think ultimately, we're all working together to create a better fabric and a system that supports people. And it's a really exciting opportunity. It's amazing to see the strategy call out so many areas and for consumers' voice and people's voice to be embedded heavily amongst that. But, there's such a huge sense of responsibility for those of us who, get to lead and undertake activity in this place, that we take it so seriously. So it's exciting.
Do you think the strategy will expand the support options available enough so that families can access the care that they need? Is that something that you think was significantly addressed? We might stick with you, Julie, and then ask the other panellists.
I think it's a really hard one, because ultimately, yes, we do hope that, the right level of funding goes to the right places within the system, and that funding also allows us to unlock some existing funding that is already there. But ultimately, if we do our job well, which is not just about responding to, but being more preemptive and, increasing the community's understanding of perinatal mental health and wellbeing and all of those juicy bits that sit around it, then we know that people's identification of distress themselves, the capacity to screen our community, is all going to start to scale up. So I think we're going to constantly be playing catch up. As Panda's saying, COVID brought about a massive increase and a doubling in the number of families and new parents and expecting parents that were reaching out for support. But that's just still growing, because we're getting better at having conversations and opening up the fact that we're all struggling. So it's a bit of a catch up constantly, I think, Sophie.
So I might just ask a few of the other panelists the same questions about does the strategy focus enough on expanding available support options? Muriel, maybe from your point of view, did it have enough in there for Indigenous families?
Look, I mean, I think the thing is there's an assumption that the mental health service is the only one that should be, delivering on mental health services. And so, and a lot of our focus is really on therapeutic approaches and not only just treating, but also working with the whole family around what's happening and being able to obviously access supports, but also being able to provide in all of our work, therapeutic and focusing on trauma and how do we heal. And I think that if we don't think of a child protection system, children are always traumatized. There's always this, an element of risk and mental health. And so if you don't have a child protection system that focuses on trauma and treatment and thinking about therapeutic, then I think we're going to overload the mental health system. So I think, I think Jill Gallagher's book spoken about VACCHOs, but I work in an Aboriginal community controlled organisation. I believe all Aboriginal organisations are dealing with a level of trauma, whether it's, colonisation, whether it's, incarceration, imprisonment. We've got the highest rates of family violence, drug and alcohol, mental health. And so all of those things, 88% of Aboriginal children come into care because of family violence. So if we don't have treatment responses, if we aren't able to look at mental health, and do a diagnosis and treatment plan and really engagement around men, women and children, then we've missed the point that our treatment response should not only focus on the family, but we all talk about children and then we go and build a system that's focused on adults. So I think how do we actually build, and look at children and actually do treatment, child really adolescent child approaches.
Harriet, what about from your point of view?
Look, I think the devil's going to be in the detail. It has to do more. We are grossly understaffed and underfunded, but I agree with Muriel. The response to mental health doesn't just lie within the mental health system. And while we're waiting for more child mental health specialists to be trained up, which will take some time, what are we doing around peer workforces? I didn't see much about that in the strategy, harnessing the lived experience. There's excellent examples of peer workforces working overseas to support parent mental health. There's colleagues in Tasmania who have parenting courses run by parents, and they require some support and supervision, but often they engage better with parents than a health professional might. And if we look at where children go for their mental health, they go to their GP, then they go to a school counsellor, then they go to a psychologist, then a paediatrician, then a child and adolescent psychiatrist. So what are we doing to support the GPs, the psychologists and paediatricians outside the formal community, child and adolescent mental health system? And we're just starting tonight a community of practice for child mental health in the northwest of Melbourne. And we had, 70 practitioners sign up over a 48-hour period. And that's GPs, social workers, paediatricians and psychologists. And they're going to get access to that very scarce resource, which is the child and adolescent psychiatrist. And we're going to try and build up their skills and confidence in managing the mild to moderate mental health problems in infants and children and adolescents. So I think I'd like to see it go further around how do we upskill the existing workforces and how do we bring peer support into it.
And Imbi, what about from your point of view? Was the focus right in terms of existing support, that services are that we need to increase the services or do what the other panelists have suggested to sort of broaden out the number of people that are available to help?
I agree with Harriet actually, and I think that the system to navigate as a mum and as a carer is just horrendous, and we spent many weekends, many nights, hours and hours just searching, and I personally don't want more, I just want better, and I want better resourced, and so that when you ring, if you need a CAT team to come to help your distressed adolescent, you can get one, not get told it's going to be 3 days and we're really sorry. I would love, I always talk about this, I would love to be captured in a system. And I think what would be wonderful is that once identified as a family that needs support, I personally would welcome that someone checking in on us and offering services that we hadn't heard of, because there's no doubt that at acute crisis, you're already at capacity. You are overwhelmed, you're trying to care for your own mental health, keep the person that you are caring for perhaps alive another day. And for another job to do, you are under so much pressure to find a service that will assist you, and you often then have roadblocks. So you find a hospital and then you find out that the doctor you're under is not allowed to access that hospital. You know, you find a support service that because of where you live, you can't go there. You find another one that you go through the whole process and think this is going to help my family, but it's not because you haven't got NDIS funding. So it's just exhausting. And I would love someone to say, you know what about this and how are you going today? Which we've actually had from police and emergency services, but not from other services.
So Imbi, just from your sort of lived experience point of view, do you think the system's getting any better for families, or do you think it's getting worse?
I would love to say better. I think what is better is that they are listening, and I think there's really good humans with great intent, and there are good focus groups and they are listening, and we have seen small changes, but unfortunately trying to access acute care has got worse. And the numbers, and we're very lucky personally that we have a great psychiatrist that holds us steady and looks after us, who I recommend everyone to. And he says to me, he's drowning in clients. So I think in that respect, that's got worse, so that parents will ring and say, Imbi, we're in a similar situation, can you help? I want to offer them help, Sophie, and I don't know where to tell them to go. So that's worse.
And look, it's very similar in New South Wales as well. There's some fantastic psychiatrists and clinicians who help look after adolescents. But I know a couple who I've recommended to people, and they've said to me the same. They've said, I can't see any more people. I just can't. You know, I've got the people I'm dealing with, I'm triaging them every day. So it's the experience is definitely not just something that's happening in Victoria.
No,
I thought
and you feel the pressure. You feel the pressure of not being bad enough. You know, I think having been in the public and the private system, you're very grateful for anything you can get, and you hope that it helps. But you can see the people working in the system that are just so spent and so exhausted. And at the end of the day, your doors close, and you hope that you can hold steady and continue the fight. But it is a fight, and it's a fight every day.
And that's why some of the things that they were talking about in that strategy, in this strategy, if they can put them into place, will be so amazing to intervene so much earlier, and these multidisciplinary teams of people having something like that for if you were having you know, issues with a child, and having access to, say, the pediatrician and the speech pathologist and the OT and the psychologist all in the one place would just be amazing for families, you know. And so instead of you having to, you know, find access to all those people, and having it all there for you would be just amazing. One thing I was interested in, this was a question from the audience as well. Professor Middeldorp said that her research showed that even after the clinical intervention, that young people still needed further support. You know, the research showed that people had improved, but that there was still a clinical, they were still showing clinical symptoms. So what's needed in terms of follow-up or other wraparound supports for a young person and their family following clinical intervention? Maybe Imbi, and then we'll go to a couple of other panelists. So from your point of view,
I think you need the ability to have consistency of care, and that in a good time you might be, you know, that's great, but then when things get worse, you can immediately access that higher level. And not only that, make sure that your story and your history does not have to get regurgitated, that it's there and it's captured in a system, because that in itself is a massive barrier. And I know my son just goes, yeah, no, thanks. I'm not telling it again. I'm not going through it again. So I think it's very important in terms of how they're going to share that through and make sure that that's transferred across from service to service and from acute to non-acute. Yeah.
And Harriet, maybe from your point of view, what advice would you have, or what needs to happen so that when people, once they finish, you know, having that the acute intervention, that there is some sort of wraparound or follow-up so that they are looked after, given Professor Middeldorp's research showed that people were still having issues even after treatment?
Yeah, look, I think in the Australian healthcare system, ideally that family can go back to a trusted health professional. Hopefully that can be a GP, or certainly in Victoria we have wonderful maternal and child health nurses who can sometimes really engage with families and hold them in that capacity. So I would hope they can go back to that person, but then that person needs support as a health professional to know how to check in and monitor, when to escalate for care, and where to and how to do that. And I think that comes back to, you know, we all work in silos. How do we actually get together at a truly integrated level? And some of that's being in the same building, co-location, but that alone doesn't cut it. You actually have to start to work together through this community, if it's a practice or whatever else it might be. So I think if a family says, I've got a GP, they know my history, they know my son's history, my daughter's history, I trust them, can they go back to that GP? But we need to support that GP or that maternal and child health nurse. And I think there's ways to do that. And then I do think we need to explore the peer workforce more in this role as well.
Definitely. And Muriel, what about from your point of view about making sure that when people, when children or young people finish having help from an acute point of view, that they're still looked after and that there's someone, checking up on them and following them up and making sure that they don't fall through the cracks?
Yeah, and I guess because, I work in child welfare and we, have in our care over 400 Aboriginal children. So from my point of view, it's really critical that we do things like we run a number of camps for young children and young people. And so it's really important. And we have elders come and talk to those young people. We also run programs, music programs aimed at, getting young people to engage around art, around ceremony, around digital platforms. And so we really and we work a lot with people that work, professionals that work with our children. I know that I used to work with Margaret Rowell from the Aboriginal Health Service, and she said that when working with Aboriginal children, that she would ask them, 85% of them, she would say to the children, draw what makes you feel safe. And she said 85% of the time Aboriginal children would draw the Aboriginal flag. And so it's the symbolic and what we do to make sure, and people, I think, underestimate how important the Aboriginal, being connected to your culture, being able to be and participate and involve, how that improves your mental health. But, we also have, as I said, we're now taking on trauma-informed. We've got an Aboriginal healing team, and they're offering to work really with some of the most complex children. And so we're training our whole workforce now. And I think that that's what all workforces need, particularly that work with vulnerable and at-risk children, to train all workforces for how to work with children. But I do see in some of our programs that we don't have access to some of the sophisticated testing, particularly in the juvenile justice system. You've got to be over the age of 16 before you can get access to some of that sophisticated just to understand the behaviours and what's happening for young people. And I think that's a critical element that's missing of this, is being able to get really good testing to be able to understand the behaviours and what's happening for children and how best to treat them. So I think there's still some gaps in how we manage the most complex.
So we've got quite a few questions coming in. We've only got about 10 minutes left, but we've got a question for Julie. Does the strategy do enough to capture families, including the child and both parents, from the very beginning?
Look, I think that's a really good question. And I think if we take it word for word, then the strategy, I think, still focuses quite heavily on the mum and the baby. And I think that we do need to look for every opportunity to be embracing and working with the whole family unit, you know, whether that is a non-birth parent, same-sex parent, or whether it's a father. We still, as a system, and Panda's system is constantly evolving in this space as well, are working towards better, including screening, responding to and providing accessible care to the whole family unit. So I think that we need to ensure that we take it that step further in translating what the strategy is giving us as a platform, and ensure that we're just doing that as a no-brainer, which is very much, you know, what I think we would all hopefully be working for, knowing that, you know, dads are as susceptible to vulnerability at this time and have such an impact on, you know, the progression of health and wellbeing as we come out the other side with families.
So Julie, you mentioned COVID's been a really difficult time, but what do you think needs to happen, or what would you like to see sort of prioritised from the strategy to address some of the things that you're seeing as a result of COVID with new families and new parents?
Yeah, I think, you know, many of the things that we feel in the kind of, well, I don't think we're coming out of it, and I hope that we don't ever kind of feel we need to go back to a way of working that we did before. I think in learning from where we've been, many of the things that we've spoken about just now are really fundamental. So we need to ensure that we're setting organisations and communities up for success by investing in the systems that support them and the people that care for them. And I, you know, Imbi, when you were speaking about that almost protectiveness of staff, you know, as a clinician, you know, I've heard myself people actually say, you know, that who's protecting the staff, you know, in all of this, and that I didn't feel I could disclose stuff because they just look so overwhelmed. Like that's such a sad space to be working within. So, you know, for me, I really do hope that the investment we've seen in acknowledging the impact of the pandemic on staff and workplaces broadly outside of the health system, but within it, really does lead to better support systems and infrastructure and funding to support staff first and foremost. You know, riffing off what Harriet said about, you know, integrated systems, I don't think there is anywhere near enough money, you know, going into supporting not-for-profits, tertiary, primary care to be building more integrated and stable systems with data parity, so we can truly start to map and understand the needs of our community, and that we're not, as Imbi said, traumatising people by repeatedly asking them for information about themselves. So, you know, I think focusing more in on that client-owned, client-held, client-respectful story that goes the journey with them is just so fundamental.
So we've only got about 7 minutes left, but I wanted to ask each of the panelists about what are the key things, because it is a very big document, it's a big strategy, it's got lots of, you know, it's a big list of things that they want to see achieved. But from each of you and your own sort of perspectives, what are you really hoping that will become a reality, so that, like we said earlier, so that these reports don't just remain, you know, reports on a shelf, but actually become implemented and become practice and improve outcomes? So maybe Imbi, just from your point of view, what would you like to see? What are the key things, you know, given your experiences and given what the strategy suggests, what would make a difference for families like yours in the future that would have improved the journey for families like yours?
In the future, Sophie, I would like care coordination. I would like care coordination. I would like a clarity of service, and I would like it to be very clear for expectations, what we can expect, what we can get, and what's available to us, and to someone help navigate and stay the course with us, whether that is for years and years. For us, it's been 8 years, and it will be ongoing, and how to flip from service to service, but at the same time have a continuation of care. Yeah. Okay, thank you, Imbi. And Julie, what about from you? What are the key things that really struck you about the strategy, and the key things that, when it comes to sort of from state and federal governments looking at what's in the strategy and what they'll implement, that you really want to see put into practice?
Look, I think ultimately just weaving together state and federal responses and ensuring that we're starting to speak a similar language, if not the same language, is really fundamental. You know, often I reflect on the fact that as state-funded services, we're almost, you know, contracted to operate in disalignment with our Commonwealth contracts as a national provider as well. So I think, you know, there's a real need to start to align those, and, you know, going back to that sort of the system enablers, I would really hope to see that the service system broadly is funded and accountable to that funding to embed a better level of system, but that that funding doesn't come at the cost of our service outputs. So we do need to be continuing to scale up our service response and being meeting people's needs where they're at, accepting that we're still a way off from getting to the ideal state in terms of how we support our community, but investing heavily in our data systems, in our infrastructure, you know, and the platforms that we work off, and our governance structures.
Okay, excellent. And Harriet, what about from your point of view? What are the
look, I think they're all excellent points made. I think I want to draw out the evaluation and measurement piece, because we, you know, in all of health, it's not just mental health, we spend a lot of money and we often don't measure the outcomes, or we have very crude measures of the outcomes. And we need to be sure, if we're going to do things differently, that they're helping and they're not harming and that they're making a difference. And who are we reaching and who are we missing out on? So that whole thing of measurement-based care, I think, is a culture we don't have in our healthcare system for physical or mental health, and that would be very complex and challenging, but fabulous to make happen. And then I do think these integrated care hubs, but I think we actually need to go further and put the lawyers in the hubs and the financial counsellors in the hubs and look at the social determinants of mental health, not just the health determinants. So that wouldn't be my dream, but I can imagine they'll be built and they'll be booked out within a few months of opening. So that goes back again to how do we support the current workforces on the ground to hold families, to help with some of that navigation in, not all of it, but some of it. And that's going back to our primary care, secondary care workforces and how we better support them.
And Muriel, just wrapping up, just finally, what are the key things that you would like to see?
Yeah, well, I think along the lines with Harriet, I do think evidence-based. I think we don't have an Aboriginal evidence menu and menu of what works in Aboriginal communities. And so we get also little funding. And I think somebody's asked about Aboriginal, what works in Aboriginal community. And I think that we know that we use lots of different approaches, but they don't meet the threshold for an evidence base about what works and what is changing. So I think from our point of view, cultural safety also is a big issue, not just putting an Aboriginal flag at your reception. What does Aboriginal practice frameworks, theoretical frameworks, how do we actually better engage? But how do we actually bring about better outcomes for Aboriginal children, and how do we know? And so I think you asked the question about our workforce and what we need, you know, and I think for VACCHO, one of the things that we're doing is introducing cultural therapeutic ways, which is about not only embedding in our own work across back in dealing and treating children, but also understanding what are the practice, how do we train our own staff, and how do we, I think there's just an assumption that because you're Aboriginal, you know everything about being Aboriginal and you can do everything Aboriginal. And so I think that all these things are things that we're still building, but I do think evidence-based and seeing Aboriginal, what works for Aboriginal, and being able to meet the threshold of evidence.
Oh, look, that's been a wonderful discussion. Thank you so much. And as a mother of 4 boys, I certainly wish there were some of these amazing things in this strategy when my children were a bit younger. And I'm really hopeful for the future that if some of these things get introduced, that the future will really be a lot brighter for families. So look, thank you so much, Muriel, Harriet, Julie, and Invi. I really appreciate your time. We're going to take a 5-minute break now. We're going to just have a 5-minute break, but then we're going to be back with a very special speaker, Professor Pat McGorry. So stretch your legs, but don't go too far away because we'll be back in 5 minutes time. So thank you very much, everyone, for your input. It's been amazing, and we'll be back in 5 minutes.
Thank you.
Welcome back, everybody. Now to introduce our next speaker, I brought a special guest, my little dog Sammy, who you may or may not have noticed she was clawing at the door a few times. So I thought I'd bring her on to introduce our special guest speaker. right now. So we've heard a lot today about a vision of a new system for mental health, but how that system will work together as a whole to improve outcomes is something that needs to be determined. And someone who is very well known to all of you, I'm sure, watching, is Professor Patrick McGorry, AO, the Executive Director of Orygen. And he very kindly recorded a speech for us. Now, there's a little bit of background noise right at the very beginning, but it does settle down. He was at Parliament recording it. So while Sammy continues to lick my hand, let's hear from the wonderful Professor Pat McGorry, and take it away, Pat.
Thank you very much, Sophie. And I'd just like to say what a privilege it is to be part of this great conference in the wake of our Royal Commission. And it was also a privilege to have had the role that I did have with the Commission as chair of the Expert Advisory Committee. And I think the Royal Commission of Victoria has been an absolutely historic event. It's a watershed. I've been working in mental health care for 40 years, and I've seen a lot of these reports come and go, and it's like the tide going in and out sometimes, or some people have compared it to bungee jumping. You have a period of reform, and then you bounce right back to where you started from, if not further behind. So I think this is very different. This is something I've never seen before. This level of expertise and buy-in, I suppose, the authorising environment that a Royal Commission creates, which is why Premier had the vision to to do this, even though some people said, well, we already know what to do, why do we need a Royal Commission? But in fact, probably largely true, we did know what to do, but we didn't have the power of community support and buy-in from both people with mental illness, the clinicians, and also the scientists, and in fact the whole community. So it's generated that, and it's been an incredibly powerful process, but also one underpinned by tremendous expertise and of all types. So very inspiring. The other big thing about the Royal Commission is that the commissioners, backed by their amazing staff team, have actually future-proofed the reform process as best they can. They've actually set up structures that, unlike back in the 90s, actually protect mental health within the health system. In the 90s, they dismantled the old system, which was well past its use-by date, but they dumped it into the acute hospital system with no protection. And of course, it not just languished, it sort of died back. And really, the future-proofing is a very important point of the Commission. And there are lots of structures like the new Mental Health Commission, the place of mental health in the department, the regional boards, the subcommittee of cabinet, and so on, a whole range of things, and financial models to support mental health care is another key bit that has to be developed further. So I think that's a real watershed. A key point is that we need inclusivity here in our reform process. Mental health has been plagued by factionalism, factional behaviour, splits, and I suppose special pleading of various groups. And what we really need is a totally inclusive approach. And I think in that we've had great modelling from Mental Health Victoria over the last 2 or 3 years since Angus Cleland took over as CEO and refashioned VicServe into Mental Health Victoria and included everybody that had a stake in mental health care, from psychiatrists through lived experience, through unions, through all aspects of the workforce and the community of practice, really. And I think that's been a great achievement. It's been a great example being set here. So just like to make that point. I think we're going to achieve this successful reform. We've got to have mutual respect between all the different parties, and obviously lived experience has gained huge respect through this Royal Commission process. But respect is a multi-directional commodity. It has to be lived in all directions if we're going to be able to work together to produce the best outcomes. I'd like to move on now to talk about some of the key features that I think are part of this Royal Commission and the way forward. I think that the first thing I want to say is that maybe I can use the word triple helix to actually talk about what's necessary for a successful reform. And the triple helix is between lived experience, which obviously was, you know, a huge pillar of the whole Royal Commission, and something that we've found, you know, over the last 10 years or so to be an incredibly vital part of youth mental health reform, involving young people with and sometimes without lived experience in the co-design and the co-production of our reforms. And this has now become front and centre in the reform agenda and through the Royal Commission. So, and I think we have to make it very representative, because you know, we've had this group of activists who've played a huge role in getting lived experience onto the front foot and front page. But we need to involve the full range of lived experience here, so all voices can be heard, and there's a range of views and opinions and perspectives here, and also families, I would say, as well, and relatives. That's another part of lived experience. Some people call it loved experience, but anyway, so that's been incredibly important as one strand of this triple helix. The second one is clinical skill and a compassionate type of clinical skill, an empathic form, which is a precious commodity, but skills and expertise are of great value. While they take often many years to develop and train and learn. I remember when I was learning how to become a clinician, after I finished medicine, I was training in psychiatry. It took me at least 5 years to qualify in psychiatry, and then some years after that doing additional psychotherapy training programs to actually develop the skills I felt I needed to do the job. So it's quite a long-term prospect for certain aspects of this, but other skills can be trained more quickly, but they are of value. And of course, they only work if they're delivered in the context of a relationship and a relationship of trust and understanding and compassion. And the third aspect of the triple helix is scientific evidence, scientific research, without which we will not actually advance the field. And innovation is a related concept, but we have to actually, like all areas of healthcare, we have to respect and integrate research with both lived experience, but also with clinical care. And in psychiatry and mental health, there's been a resistance to this from clinicians to integrating research. And so we've got more challenges with this integration of this triple helix in mental health care than we do in other parts of healthcare, I think. So, and I think the concept of the collaborative centre is very important from this point of view, integrating those three things. I believe we've made huge progress at Orygen, integrating all those three strands already, and it's been a key to our success, having those three things equally respected and synergising each other, which they do. So in a way, we need head and heart here. That's what we're saying. Second major feature of the Royal Commission, which is, I think, absolutely addressing a huge gap, a thing that was bringing us undone really across the board, is the idea of staged or stepped care. Staged care is a better concept because it's more proactive and it's trying to get ahead in a preventive sense of the steps of care. So not waiting till people feel worse and become more disabled or impaired, but actually trying to prevent that from happening by proactive treatment and prevention. And of course, the missing middle is the concept that we developed, actually, that's been taken off around the country now, which captures the fact that there are very few steps or stages in between the very mild primary care end and the desperately ill, desperately severe, crisis-ridden acute end. And obviously everyone recognises now we have to build these stages and steps if we're going to actually take the pressure off that acute end, so we can actually function in a much more humane and compassionate and effective way. But also actually reduce the impact of mental illness across the lifespan and across the stages of illness. And a related idea in terms of building these steps or stages is having structures, visible platforms of care in the community, close to where people live, as the Premier said, treating people early and locally, and for as long as they need it in a timely way. And the centre of gravity, this concept of the centre of gravity, has to be in the community, not in emergency departments or acute inpatient units, which is where it's drifted because of the failure to build the rest of the system. So all of these things have come out of the Commission, and not only that, but we have a blueprint for actually how these things can be done and executed into the future, always with the benefit of lived experience, scientific expertise, and clinical expertise and skill. And I mentioned the future proofing. I'll just go through some of those points again. The Mental Health Commission, the increased status and power really within the Department of Health, having a DepSec, Deputy Secretary for Mental Health, reporting to the Secretary. Regional boards, so that the commissioning of mental health services isn't just automatically handed over to big hospital networks, but it's actually commissioned on a regional basis with a community focus and with accountability for the provision of the services, so that there'll be transparency and accountability about how these services are actually delivered. And of course, the levy as at least a partial contribution and an insurance policy concerning the funding of mental health care and reform going forward. The other feature I've mentioned already that I think is a very critical pillar of the reform process is the Collaborative Centre for Adult Mental Health. Now, it seems to have been a bit of mission creep here, because it was originally conceived as a adult psychiatry, adult mental health collaborative centre, recognising that we already have one in Orygen for youth mental health. And we've obviously got the Murdoch for younger children, which has got capacity in the mental health research in younger people. But the Collaborative Centre is important because adult psychiatry over the last 15, 20 years, its research and innovation capacity has suffered a lot with the neglect of the system. And we lack a new generation of young emerging researchers and expert clinicians to kind of lead and work with people with lived experience to actually produce and support a better system. We need this focal point. We need this support system in the way that it's working in youth mental health with Orygen. And I think the Commission recognised that. They also looked at other similar models like the VACCHO for cancer, where you're integrating research, clinical skill, and lived experience as well. And so it's a very important missing piece in terms of sustaining the reform, because without clinical expertise and research, partnering with lived experience, you don't get innovation, you don't get good cultures of care. It's essential to have all of these things operating. Okay. Another point that we need to think about, and which everyone is talking about now, is workforce. And we need to have a short to medium term strategy to drive these reforms and obviously attract people back into the workforce, find workforces from elsewhere, develop new workforces, and also have a longer term strategy to open the channels, to open the bandwidth of training in various disciplines like occupational therapy, psychiatry, social work, psychology, peer work, and so on. We need to have a very wide channel if we're going to staff the kind of system at the scale that needs to be staffed for the longer term. Another point is research and innovation, which I mentioned already in relation to the Collaborative Centre. We haven't got equity in the funding of mental health research within medical research. We currently receive about 7% of the research funds or less in terms of the MRFF. And obviously mental illness is somewhere between arguably 12 or 13% of the burden of disease, as high as 20%, depending on some calculations of this. So equity and respect within medical research is vital. Australia's mental health researchers are ranked 5th in the world in terms of the quality of their mental health or medical research. And that really outranks our immunology and cancer researchers, who only rank around somewhere between 8th and 11th in the world, even though obviously it's high quality. But we haven't got enough of those mental health researchers. They're few in number and probably in scale well behind cancer and other major areas of research, even though the quality of what they do is very good. So we need to beef that up big time if we're going to drive reform and better quality care. We need new treatments, both psychosocial and biological or medical. The existing medications work for many people, but not for a significant minority, and they often have side effects. So we need more effective and safer medicines to actually treat these illnesses in a better way. We need more options. And unfortunately, the pharmaceutical industry has, in the recent years, walked away from mental health because they found it to be too hard. So we've got to kind of find a new way forward and re-engage them so that they can play their role in helping us to develop new medicines. Same with psychosocial treatments. There's been a stagnation of innovation in that space too, which technology through digital and also through virtual reality and other approaches like that can help us regenerate and perhaps make more attractive and engageable and more effective too. Lived experience, I've mentioned that already, but I think we really need to get a much wider spectrum of people with lived experience involved. There are several groups of people with lived experience that are not properly represented at the moment. And there's not a wide enough spectrum across the lifespan nor across different socio-demographic groups to really say we're capturing the full spectrum of lived experience. And if we're going to be really democratic about this, we need to make a much bigger effort, which is why we've set up an organisation called Australians for Mental Health, which is meant to be a mass social movement in the long term. And it's already made some very good partnerships with Mental Health Victoria in relation to lobbying and advocacy around adults' mental health hubs, for example. So I think that's the future, to get really a much larger proportion of the Australian public who are affected by mental ill health involved in the lived experience movement. And I think one of the recommendations of the Commission might help us to do that if you look carefully at that. Families and peers, relatives, friends, that's another very neglected area, which again has received strong support with the recommendations of the Royal Commission. However, there's often resistance to this happening, and we need to overcome those sources of resistance. I've tried for many years for the youth mental health area to have families more centrally involved, but it's a challenging reform to make, but we're making a lot more progress now than we have in the past. Turning to the clinicians, in my speech at the launch of the Royal Commission report a couple of weeks ago, I basically tried to highlight the lived experience of clinicians within a system that had been imploding and collapsing over the last 15 years. And it hasn't been a positive experience. The workforce has been very poorly supported. They've been placed in positions where they practice in a way they must feel very uncomfortable about, and that includes issues like restraint and seclusion, which I don't think clinicians really ever want to be in that position if they didn't feel there was no other choice. And certainly I'm personally very committed to seeing that fade away and hopefully die out, because there must be a way of doing that. And I've seen that happen in some places in the US and other countries as well. So I think it's feasible. The other thing is the moral injury I referred to, that clinicians are forced to turn away people they know are seriously ill every single day. Other healthcare professionals don't have to do that, not in the same way. So it's a very bad experience that has been imposed upon our clinicians who go into this field with a great deal of care and altruism, I think, at the beginning of their career. So we've got to look after them, revive them, regenerate the workforce, and support them. If workforce is going to be a challenge, widening the channel, the bandwidth, how are we going to do that if we don't respect and value the work that they do and help them to do it? It's a very challenging job, very challenging compared to many other health care professional roles. So they've got to be respected and not blamed for the mistakes of the system has imposed upon them and everybody else in the past. We have an authorising environment to do that now. On the other hand, I think a lot of the lived experience that came through in the commission highlighted the ways that professionals need to improve their work practice. It's not just having a more compassionate and caring attitude, which will come from better morale of their own, but more flexibility in the way people work. Obviously, boundaries are important in working as a mental health professional, but they shouldn't be rigid. They shouldn't be distancing from patients and from people seeking help. And flexibility about how assessments are done, where they're done, operating hours of work. They should be at the convenience of the consumer, not at the convenience of the professional, completely like it currently is. So I think major reform in work practice and attitudes, no more us and them, basically. So the us and them dynamic impacts on clinicians who may actually have that attitude, but sometimes consumers have that attitude too. So we've got to overcome that, and it's helpful to no one. We're all human beings, and we all have issues of mental health and mental ill health, either in ourselves or in our family. And up to 84% of people will actually have a period of poor mental health across the lifespan. So my slogan is no more us and them. I think this extends into the way the facilities are actually organised in terms of the kind of almost like the Fort Knox design of many community mental health services. They shouldn't be like that. They should be much more open access sort of areas and welcoming, and with little distinction between the staff and the people who are actually using the services. So a one-stop shop with a very welcoming and flexible approach. Finally, the political environment. I think we've never seen such a strong authorising environment, certainly not in Victoria, but maybe even nationally, for reform and investment in mental health. So we must take advantage of this. And the best way to do that is by sticking together, trying to iron out any differences of perspective and being tolerant of each other. I think we have to tolerate other perspectives and try to understand why people think and feel the way they do, whether they're professionals, consumers, researchers, trying to see things from the other person's point of view. And I think that's usually a very helpful approach, and having respect for what everyone has to offer. I mean, it sounds too easy. It sounds simple to say, but often hard to actually achieve in practice. So just I'd like to begin to wrap up here. I would like to acknowledge, as I say, that the wonderful example that Mental Health Victoria has set for us as a field by being inclusive, being respectful, being tolerant, and allowing everyone to have their point of view and trying to learn from each other. I think that's been great leadership. And, I think it's going to stand us in very good stead. And holding this forum is part of that, and helping us all to come together. I mentioned Australians for Mental Health as a way of broadening the consumer voice, and I think the government's recommendations for a new body or a new lived experience system or model, I think it is definitely going to help too. We will need to be vigilant. We will need to continue advocacy in the longer term to make sure that the momentum of these reforms does continue. I think I've seen these bungee jumping sort of episodes in the past that I mentioned at the beginning. I certainly don't want that to happen this time. I don't think the government does. And they've tried to lock in as much of future-proofing as they can. So do feel very optimistic about the next few years, and you know, we should be very inspired and full of energy and enthusiasm to make this work. Maybe this is the watershed that we've been waiting for a long time. And if it does actually come to pass that this is the case, and we can bring this triple helix together, we will actually see Victoria become the absolute epicenter of quality mental health care, not just in Australia. I think we will influence other states, because I'm up in Canberra today. I'm recording this in Parliament House. We're having discussions between state and federal governments about partnering around the Victorian blueprint and building on that to extend it across Australia. That's the goal that governments have, and to bring in the other state governments into the mix by the end of the year into a national agreement. Now, obviously, to change the landscape, it will take a number of years, but we've got to keep the momentum up. And I think Victoria could well be, and probably will be, the epicenter or the showcase of this, if we all do our jobs in a respectful way and a dynamic way too. And of course, if Australia and Victoria do this, then that will have a profound influence on the rest of the world. Much of the innovation in mental health care over the last 20 or 30 years has come out of Australia, and other countries have actually adopted it, especially early intervention, home-based treatment, and youth mental health. They're just 3 examples, and probably digital health is a 4th one. So I should have mentioned that earlier as a key innovation front that has to be part of modern mental health services. So now, clearly, I haven't covered everything today. I've just picked out a few things to focus on, and I suppose my main message, and I really hope people can buy into this in a collegial sort of way, is inclusivity, respect, tolerance, and also innovation. I think those are some of the secret ingredients that we will need going forward. So thanks very much for listening, and I really hope the whole conference day goes well. Thanks, Sophie. Back to you.
Thank you, Pat, and apologies for the little technical issues at the beginning, but we got there in the end, and it was very worthwhile to hear Professor Patrick McGorry, his great thoughts, his great words of wisdom, and really valuable insight into putting it all together. Now, because we had a bit of a disruption, we're going to go straight to our closing address. Jill Gallagher AO, the CEO of the Victorian Aboriginal Community Controlled Health Organisations, is going to speak to us now, and she's going to give us our closing address, and then I'll be back at the end just to wrap up and say goodbye and talk about some exciting things coming up in the future. And if we play our cards right, I'll see if I can get Sammy to make another brief appearance for our final goodbye. But we're just going to wait to hear from Jill, who's going to, here she is. Wonderful to have you on board, Jill. So I'll say goodbye if you unmute, and we'll hand it over to you. But welcome, and look forward to hearing what you have to say. Thanks so much.
Thank you very much, Sophie. Thank you very much, Sophie. Thank you, everyone. And I caught the tail end of the previous presenter, and I found it very informative. But before I begin with this closing address, I would like to pay my respects to the traditional owners of the lands of which I am speaking to you today. Wherever we are on Aboriginal lands, lands on which sovereignty has never been ceded. I'd like to pay my respects to elders, past and present, and everyone who's on this symposium today. I'd like to also thank Mental Health Victoria for the kind invitation to speak with you. I feel very privileged and very honoured. My name is Jill Gallagher. I am a proud Gunditjmara woman from Western Victoria. My country, it actually reaches from South Australian border through to Portland, down to Haywoods and down to the ocean. I'm currently the CEO of VACCHO, the Victorian Aboriginal Community Controlled Health Organisation, and I've been the CEO of VACCHO for some 22 years. But I took a little bit of a pause and spent 2 years as the former Treaty Commissioner here in Victoria. VACCHO is the peak body for Aboriginal health and wellbeing in Victoria, and we are the only one of its kind, with 32 Aboriginal community-controlled organisations who make up our membership, who make us who we are at VACCHO today. VACCHO members support over 25,000 Aboriginal people across Victoria, and combined, we are the largest employers of Aboriginal people in the States. Today, I want to talk to you about the unique Aboriginal understanding of mental health. I do need to basically say up front, I am not a mental health expert, but I have worked and lived in my community for many years and have seen the devastating effects of mental health in my communities. And we are overrepresented in the mental health system. But for Aboriginal people, mental health is holistic. It is about the mind, the spirit, the body, and it's about connection to country, kinship and community. It's about taking care of our well-being to heal. VACCHO and the Victorian Aboriginal community have been heavily involved throughout the work of the Royal Commission into Victoria's mental health system. We shared our holistic view of healing and mental health, which draws upon ancient wisdoms that have evolved over many, many generations. And through the sharing of this Aboriginal wisdom, I'm proud to say, there has been a reimagining of the mental health system for all Victorians. We can see our holistic model of healing and mental health strongly reflected throughout the whole of the Commission's final report to Parliament. Specifically for Aboriginal people, we hope to see a new system of healing that integrates the contemporary and the traditional, the cultural and the clinical. And that's what I want to talk to you about today. The Commission, combined with the strategies we have discussed in the panel sessions during the symposium, marks a turning point in mental health services delivery in Victoria. This is a moment in time, and I think we can imagine a better future for 2030. But before I go on, I'd like to thank everyone who has spoken and contributed their ideas to this symposium. Our discussions illustrate the wealth of knowledge and the deep passion across the country to ensure that people affected with mental health get the care that they need it, but more importantly, when they need it. That sets us in good stead for a better future. I think it is fair to say that the overwhelming call from our symposium today is for mental health to be prioritised at a national level. We need state, territory, local and federal governments to work together with a coherent national plan and supported by a significant investment right across the board. We would like to see the federal government make mental health a major priority in the up and coming May budget. Again, I'd like to thank all of you for your meaningful contributions throughout not only this symposium, but throughout all the work that we've all done through this inquiry. In making this closing address to the symposium today, I'd like to take the time to share more about Aboriginal ways of healing. Because I think there is something to learn for all of us here in Victoria. I'd like to paint you a picture of a new Aboriginal-led social emotional wellbeing service system that I believe is about to emerge. Founded on the expertise of Aboriginal community leaders, of Aboriginal people with lived experience, and coming into reality through, and all this coming into reality through the Royal Commission. It is based on the values of connection, connection to culture, connection to kinship, and connection to community. For too long, our people have fallen through the cracks of a fragmented and culturally unsafe mental health system. One that fails to recognise the wise and ancient cultural values of our peoples right across this continent. There are some alarming statistics that I'd like to share with you. And while these are statistics, facts and figures, for us, they are stories and they are real people. 1 in 3 Aboriginal people have a high or very high levels of psychological distress. Mental health related emergency presentations are 4 times higher for Aboriginal people. The national suicide rate for Aboriginal people is estimated to be twice the rate of the general population. And suicide among Aboriginal people generally occurs at a very much younger age. Nearly half of all Aboriginal people in Victoria have a relative who was forcibly removed due to the stolen generation, or in fact, they were taken away themselves. Ongoing colonisation of our people has left a legacy of grief and trauma. Trauma that compounds the mental health issues. And I strongly believe something needs to be done and something needs to change. I'd like to take this opportunity to share a brave story of a young Aboriginal woman which highlights the deficiencies in our mental health system. Tamara Lovett is an exceptional young Aboriginal woman who shared her traumatic experience before the Royal Commission. Stories like hers are what bring the final report to life and sustains the tireless work that we do to create a better mental health system for all Victorians. A proud Gunai and Gunditjmara woman, Tamara grew up in Melbourne and struggled with mental health from a very early age. She alone bravely stood before a large crowd and shared her personal journey at the Aboriginal Day of Hearings. Tamara spoke about her time as a young pregnant woman seeking support when the health system made her situation worse rather than better. At the age of 19, she was expecting her very first baby. Tamara had a great relationship with her local GP. She had a mental health plan in place and she was referred to the local hospital, of course, to have her baby. However, the system did not allow for her local GP, her trusted support person, to remain involved in her care. In Tamara's own words, I was not at risk. I just wanted support. Upon entering hospital to get support with her pregnancy, Tamara was immediately referred to the CAT team without her knowledge or her consent. When interviewed by the CAT team, Tamara stated that she felt bombarded with questions and stressed out. Tamara said she was put on different medications that made her feel worse and not better by the treating team. And she was told that her GP would no longer be involved in her care. This is a critical mistake that undermined her autonomy, decision-making, and right to self-determination. It also disconnected her from her trusted support person. Tamara, like many Aboriginal people, was already hesitant to engage with the hospital because she had heard the horrific horror stories about the way some Aboriginal people were treated and are still treated today in hospitals. And like many young Aboriginal women, Tamara had heard about other Aboriginal women having their babies taken away. This is a common fear for Aboriginal women and families seeking support through hospitals and other mainstream services. This speaks to the high rate of child removals in this state and to the traumatic history of the stolen generations. Tamara went on to speak about the failure to the hospital to understand her trauma and her cultural needs. At VACCHO, this is a story that we hear a lot. She described being forced into treatment that she didn't want at the hospital and not feeling represented. This is why it's so important to have trauma-informed care and Aboriginal people working in mainstream systems in partnership with Aboriginal community-controlled organisations who also deliver some of these services. Tamara's witness statement, which you can read online, is damning. It doesn't just detail this event, but years of Tamara actively seeking support, only to fall through the cracks. This story points to a widespread trend experienced by Aboriginal people seeking mental health services. It highlights a lack of appropriate services. It highlights racism. It highlights being misunderstood culturally, being isolated, or feeling a lack of connection and empathy from support workers. Some of the time she was really in crisis when she called out for help, but didn't get it. Tamara also mentioned her positive experience, such as going to Aboriginal specific services to get help with housing. Amazingly, Tamara went on to work with an Aboriginal outreach support worker, as an Aboriginal outreach support worker. Today, she provides great support to clients with mental health services and also drug and alcohol, housing, other services informed by her own experience. Tamara's story shows us that we need to do things differently. The whole system. So my question is, how are we going to do things differently for Tamara and people like Tamara? Ballot Dern Dern, which is this publication, is VACCHO's report to the Royal Commission. It brought our solutions and our voices directly to the Commission. Ballot Dern Dern means strong brain, mind, intellect, and a sense of self. It's in Wairong Wurundjeri language. In it, there is an Aboriginal-led roadmap to dramatically transform the Victorian mental health system. Aboriginal stories are at the heart of Ballot Dern Dern. And our strength is in our stories. We spoke to Aboriginal people experiencing poor mental health. We spoke to their carers and families, as well as Aboriginal leaders, elders and workforce. And we are very grateful to everyone who contributed and shared their stories and their expertise. Whilst Ballot Dern Dern speaks to a deep sadness and frustration that comes with decades of intergenerational trauma entrenched in Australia's colonial history, it also highlights Victorian Aboriginal communities' courage, our resilience, and our sense of hope that we will get it right. Stories, truth-telling, and culture are at the heart of healing. They are our best medicine. I want to commend the Commission on picking up these community voices and accurately reflecting them in the interim and the final report. Ongoing colonisation of our people on sovereign lands has left a legacy of grief and trauma that compounds mental health issues. This is well documented, and importantly, the Royal Commission has recognised this impact. The Commission also acknowledges the important role of culture, identity and connection to country for Aboriginal social emotional wellbeing. Social and emotional wellbeing means being resilient, feeling culturally safe and connected, having and realising aspirations and being satisfied with life. We are blessed to see that Aboriginal understanding of holistic mental health care embedded in community are being brought into the mainstream through the final report's recommendations. VACCHO is excited to play a leadership role in this new mental health system, drawing on the expertise and experience of Aboriginal people and organisations, but all the expertise and all the people who work in this space, not just in our communities. As a result of the Royal Commission, we are now going to see, hopefully we're going to see a system-wide reform. 2 new Aboriginal healing centres will be set up in Victoria. They will likely be a mix of culture and clinical models of care. But ultimately, our communities will decide how they look, and they will be locally led. Healing centres will provide a place for Aboriginal-led trauma-informed healing, restoration of languages, use of knowledge systems, kinship, connection to country, which will all be fostered through the healing centres, are in line with the focus on families. And that came out loud and clear by the Commission. The healing centres will also create paid employment opportunities for elders who will play a critical role in healing of our young people and of our communities as a whole. We additionally welcome the final report's emphasis on the need to support parents, families and communities to be mentally healthy so they can raise our burais to be resilient, strong and grounded in culture. I'd like to, at this stage, to acknowledge an elder, Auntie Melva Johnson. Auntie Melva Johnson said to me some 30 years ago, she said, "Jill, if we do not grow our burais strong in culture and connection to country, we will always have issues in our health systems and mental health systems." So I've listened to the wisdom of elders, and it is critical that we grow our burais strong in culture, strong in identity, strong in connection to country. And Burais, for those who don't know, we're talking about children and babies. VACCHO will also be set up as a Victorian Aboriginal Centre of Excellence in the social and emotional wellbeing to foster innovation in social and emotional wellbeing practice, policy and research. And we are so very excited about this opportunity. We'll also see the setup of 22 social emotional wellbeing teams across the state. They will build on existing teams that are currently out there also. There will also be new supports for babies, children, young people. There will be a network of healing across this state of Victoria. In closing, I'd like to say I'm very excited about the meaningful, sustainable and long-term overdue changes that the Commission outlines in the report. Aboriginal people and communities stand in unity with all communities across Victoria who have been calling for change. And we are very excited to collaborate with the system to create a fairer and more holistic mental health system for all Victorians. As Professor Pat McGorry, AO, put it in his launch at Parliament of the final reports, and I quote, "In the treatment of cancer, the top priority is to detect and treat the person in the very earliest stages of illness, not to wait until it has advanced to a late stage or treatment is ineffective or too late. We would not dream of turning away 2 out of 3 people with chest pain or an early breast lump and dismiss them with the notion that their illness is not serious enough to deserve care," unquote. If we can get this right, we can really change the experience of people in the mental health system. And when people are supported to be mentally healthy and well, they can better lead the next generation into a brighter, more inclusive future and society. I believe Victoria can show the way. Thank you very much.
Thank you so much, Jill. That was a wonderful talk. We really appreciate it. So inspiring, and thank you for sharing Tamara's story as well. That was very powerful and one that certainly will stay with me for a long time. You know, those lived experiences and those stories, they make such a massive difference, and we really appreciate you sharing that with us today. So thank you very much. It's been wonderful having you as part of the symposium. So look, I'm just going to briefly wrap up today's events. It's been an amazing discussion and a wonderful day for the future of mental health. Just a few housekeeping things. We will be sharing the slides from today in the next couple of days to everyone who was registered. Also, if you do, we would love you to fill in the feedback survey as well, which would be amazing. The exhibitor room will be open for another, at least till 3:30, and the link is in your program, so we'd love you to go there as well. We've heard about all the different reports that have come out, but there were, I think, in our discussions, some really key themes that came through: the importance of lived experience, the whole of life and the whole of system approach, the outcomes measured, sustainability, flexibility, adaptability, and person-centered care. And so I think that's something that we can all hold on to, even though there are a number of reports, they're all really wanting the same thing. And I just want to thank everyone for your input as well. We've had lots of amazing questions coming through, and that's been so good to get your questions to the experts we've had here today. There's also a lot more coming up from Mental Health Victoria. You can see on the slide right now that we've got 2 more symposiums, one on the 19th of May, which is called Preparing for Reform, Co-Design, Service Delivery and Service Culture Change. And on the 21st of July, there's one called A New Model of Mental Health, Community Mental Health. So we would love you to register for both of those. And it's been great to see your support on social media as well. So if you are on Twitter or Instagram, you can follow Mental Health Victoria, and my handle is @SophieScott and the number 2. We talked a little bit about workforce issues, and I'm going to be posting some things, particularly on my Instagram, about burnout and dealing with the caring professions and how we deal with ongoing trauma and things like that. So it's been amazing having you as part of this symposium. Thank you for your involvement. And yes, if you wouldn't mind filling in the feedback, you'll get the slides, and we hope to see you. And I'll just show you, I did bring my special guest to say goodbye as well. So it's a goodbye from Sammy. Goodbye from Sammy, the caboodle, and we will see you next time. See you then.